Hello, thank you very much for the presentation. I'm going to chair the first session of this meeting. I believe it's going to be really interesting, and I'm going to share the screen right now. Let me see if it works. Okay. Can you see my screen? Okay.
Yes, absolutely.
Okay, thank you. I'd like to congratulate ELA for the first 30 years of promoting the research on leukodystrophies, and I encourage them to follow in the same direction for at least the next 30 years. So here is the program of the meeting. I'm going to start with talking about megalencephalic leukoencephalopathy with subcortical cyst, MLC. And then Marjo van der Knap will follow with vanishing white matter NKH syndrome. Then Annette Blay with Canavan disease. And then we will have a technology seminar about mini brains as a model for rare brain diseases. And we follow Angela Gritti and Vasco Menettini with Alexander's disease. So we will have the questions at the end of the session. So for all you that have questions, we will answer them at the end around 4 o'clock. Okay, I'm gonna put up my presentation right now. And okay. Okay, so I'd like to acknowledge ELA for inviting me to this meeting. I think this is really fair for the patients and the families to know what are the progresses going on their disease. And also it's for the scientists is actually what gives sense to our research. So I think this is a really good initiative. I'm going to start with a couple of slides talking about the disease. MLC is an ultra-rare neurological disorder that is caused by mutations in MLC1, mostly MLC1 gene, but also some patients have glial CAM, mutations in glial CAM. MLC1 is expressed in astrocytes, while glial CAM is expressed in astrocytes as well, but also in oligodendrocytes and some neurons. Most of the patients that show MLC, they have recessive mutations, means it's inherited in a recessive form. So both parents have to have one allele mutated of the gene. And this happens for all MLC patients, but also for most of glial CAM mutated patients. The clinical manifestations of the disease are mainly cerebellar ataxia, macrocephaly, which is the most evident feature, spasticity in some cases, epilepsy, which can be aggravated by mild brain traumatic injury and a mild cognitive decline. But there are also another form of the disease called MLC2B, which courses with dominant mutations. However, these patients, although they show macrocephaly at the initial at the first years of life, they have reversible symptoms. So this is something which is characteristic of this dominant form of the disease, but also few patients with the recessive form also have shown this reversible symptoms lately. And all these symptoms are probably due to this or histopathologically, we can see myelic vacuolation, which is probably due to the changes in the water content of the brain. So we can diagnose MLC by MRI, and here you have some characteristic images of this. For the classic MLC, the recessive form, over time there is at the beginning there is a white matter swelling which decreases over time, and the subcortical cysts may increase. You can see here a very big one which occupies most of the brain. While for the remitting form of the disease, the dominant form, the abnormalities are present at the beginning of the disease, but then they decrease over time, and finally can appear almost normal. So Dr. van der Naap, who in fact described the disease in the 90s, had also described the progression of the disease in quite an important number of patients. And you can see here that for the recessive form of the disease, the onset of motor deterioration starts very early, during the first decade, and about half of the patients become fully wheelchair dependent, and also the onset of seizures are also starting very early. However, for the dominant form of the disease, the symptoms are really mild, and only some seizures are apparent in these patients. So this remitting form of the disease was actually our point of start on defining the treatment of the disease, as we thought that this could mean that very small amounts of the protein may be necessary, and we could also reverse the pathology in not only in the MLC2A, but also in the MLC1 patients. The actors in these pathologies, I told you at the beginning, are the MLC1 protein, which is a membrane protein, and the glial CAM protein, which is a cell adhesion protein of the immunoglobulin family. MLC1 is expressed only in astrocytes, as I told you, while glial CAM in oligodendrocytes and astrocytes, and MLC or glial CAM regulate the expression in the membrane in the localization in the membrane, one of each other, but also other actors may participate in the function of MLC and glial CAM, since it had been demonstrated that CLC2 also is mislocalized when glial CAM or MLC1 is missing, and CLC2 is a chloride channel. So ion channels may be involved in the development of the pathology. And there are a few animal models of the disease. In fact, the knockout animal model for MLC1 or the knockout for glial CAM show some symptoms of the disease, like the vacuolating phenotype. Also CLC2 knockout mouse model, although there are not patients so far described with these mutations. And at the ultrastructure level, we can also see these very huge vacuoles that are affecting the oligodendrocytes in the white matter of the cerebellum, which is the only structure in the brain so far that is affected in the mouse model, contrary to the patients. The other problem in this model is so far we have not been able to see behavioral phenotype, so it's considered as an early stage of the disease model. MRI is also able to detect the pathology, the brain lesions here in the cerebellum of these knockout animals, while in the wild type, this is completely clear. So in the mouse model, we only can detect the progression of the pathology. So to start with this, with a new therapeutic strategy, we decided to use adeno-associated vectors. And adeno-associated vectors have been demonstrated to be really efficient for muscular, spinal muscular atrophy, for example. And contrary to retrovirus or lentivirus or integrative vectors, most of AB vectors do not integrate, which is good to avoid insertional mutagenesis, which have been giving some deleterious effect in some of the treated patients so far. So these are completely gutless vectors. So we eliminate the viral genes in the AV and substitute it by the therapeutic gene and also the regulatory sequences. And it had been demonstrated very long-term efficiency. For example, in the brain, here in a primal model of Parkinson's disease, which with one single shot of the vector in the brain, it's able to express the therapeutic protein for more than 15 years. So this is really encouraging. So we started with a vector here that only expresses GFP as a reported gene under the regulation of a GFAP promoter. As you remember, MLC1 is expressed only in astrocytes. And we injected the vector into the CSF at the cerebellar level, so as intrathecal administration between the bone and the cerebellar parenchyma. And we see that we can transduce very efficiently the cerebellum of these mice, and that the GFE expression colocalizes with MLC1 in a wild-type animals. So we set up a therapeutic strategy where we treated the animals as in three different ways. First, as a preventive study, where we treated the animals before the onset of the disease, when they are 2 months old, or at just 1 month after the onset of the disease, at 5 months of age. And we analyzed these animals at 8 months of age. And finally, we did also another study, which we called late therapeutic, because we treated the animals at 15 months of age. The mice only live for 24 months. So 15 months of age is more than middle age for these animals. And so the disease had been showing the pathology for many months, and then we analyzed them at three months later. So as you can see here, the null animal do not show MLC1 immunofluorescence, neither glial CAM nor CLC2, because they cannot be localized in the membrane if MLC1 is not there. While in the wild-type animal, we do see the three proteins in the Berman's glia of the cerebellum. And this correlates with a vacuolating phenotype in the knockout animal. When we administer the MLC, protein, we do see glial CAM expression and CLC2 that colocalizes with MLC1, and this leads to a decrease or almost disappearance of the vacuoles in the white matter of the cerebellum, which is pretty similar to what we see in the wild type. This was the data that we obtained for the preventive study, but we obtained the same pathology for the early therapeutic study. And when we treated the animals with 3 different doses, we do see correlation both in the expression of MLC1 and in the vacuoles, the number of vacuoles, depending on the dose, which shows that it's consistent with the expression of the therapeutic protein. Here you can see the results on the long term at therapeutic study. Sorry, not long term, late therapeutic study. And you can see that we obtained the same results as for the preventive, which supposedly was easier. Here you can see that the animals that were treated at 15 months of age, 3 months later, they do not show the histopathological feature of the disease, the vacuoles, very similar to what we see in the wild type, showing that, in fact, there is a large window for treatment of this disease because it's not a neurodegenerative disease. So the patients could eventually be treated even at later stages of the disease. The ultrastructure of these brains treated with MLC1 was very similar to the ones of the wild types, and dramatically different from the null animals that treated with the null vector. This was quantified, and you could see that the number of vacuoles in the treated animals was very close to the wild types. And this can also be analyzed by RMN. Here we have the MLC animal, where we can see the cerebellar lesions here in a white way here. And when we analyze the treated animals by MRI, we see that these lesions were clear. And this can also be quantified. And we can see that there is important decrease, compared to the untreated animals for the MRI, which this gives us a tool to monitor the effect of the therapy when the animals are still alive. But as a proof of principle, we wanted to see if this also worked for the glial-cam mouse model. So the glial-cam expression is more challenging because we need to express it both in astrocytes and also in oligodendrocytes. So we can use the same promoter as for MLC, but we need also another promoter to express glial-cam in the oligodendrocytes. And here we use the myelin basic promoter. And we injected these animals with the same method as we did before. When they were already old, like a late treatment study at 15 months, and analyzed them histologically 3 months later. So here you see the results for the glial-cam expressed in astrocytes. We do see expression of glial-cam and also MLC and CLC2 in the treated animals, while it's absent in the non-treated animals. And here on the pink, in this curve, in the last images, you can see the overexpression of the lack of glial-cam. There is a great number of vacuoles. In fact, we do see a worse phenotype in the glial-cam mouse than the MLC one. And the number of vacuoles has almost decreased to wild-type levels in the treated animals, as you can see in the quantification. So this was with a similar vector that we use with MLC, but for expressing glial-cam in the oligodendrocytes, we needed the other promoter, the myelin basic promoter. And here are the results of expression of glial-cam in oligodendrocytes. So in the MRI images, you can see the lesions in the cerebellum of these animals, the untreated animals. And here you see the results after the vector that expresses MVP, glial-cam through MVP that is in the oligodendrocytes. And you can see that the phenotype is pretty similar to the wild-type animals. The quantification of the MRI also gives us a decrease in the number of vacuoles on these animals, which is in fact not statistically significant compared to the wild types. But the histology is what gives us the confirmation of this. While in the wild type animals there are no vacuoles in the white matter, the glial cam animals have a huge vacuolization in the white matter, and the MVP animals have a much reduced number. We're now quantifying this. And the other thing that we still don't know, and we are in the progress of analyzing it, is if with a combination of both vectors in these animals, we could achieve even better results. So as a conclusion, we could say that by administering these vectors, MLC or glial cam as well, we can correct the histopathological features of the disease in the animal model, and we can restore the mislocalization of the missing proteins that cause MLC in two animal models of the disease. So with the help of CIBERER in Spain, we applied for an orphan drug designation for these vectors, and this was granted by the European Medicines Agency in September 2021. And finally, we're continuing our experiments on this disease because the animal model only have the pathology in the cerebellum, but we know that the patients need to get the whole vein transduced. So we're looking for vectors that would be able to cross the blood-brain barrier and transduce the glia through the circulation without using an invasive technique like the one that we have been using in this project. This is just one vector that was described a couple of years ago. It's a variant of AV9. AV9 was described as being able to cross the blood-brain barrier. And you can see a very few cells that after injecting this vector in the circulation get transduced. But this new variant, as you can see, it's really makes a huge difference when injected in the mouse. This applies for neurons, and now we are trying to get to explore the results of using some of these vectors with glial promoters. So this is just the end, but the most important slide. This project is a collaboration with Raúl Estevert and Virginia Nunes, and also Miguel Chillón, which is in charge of the viral vector production unit. And this is what was being done basically by Angela Sanchez with the help of Alejandro Brau and funded by ELA International in the call in 2018. So I'm gonna stop here my presentation, and I'm going to introduce the next talk, which would be the one by Marjo van der Nap. Let me see if I can find it. Sorry. Oh, it's not that one, sorry. Well, anyway, here, okay. Okay, so it's a pleasure for me to introduce Marjo van der Nap, who is going to talk about vanishing white matter and Kite syndrome. I'm afraid I cannot hear you, Marjo.
Yeah, we cannot hear you, Mario. We cannot hear you. I believe she's coming back, trying to get her microphone working. So we'll have to just be a little patient.
Can you now hear me?
Yes,
yeah, perfect.
absolutely. Thank you.
I going in and out, that helps a lot. I'll share my screen. Yes. So can you see my screen?
Yes.
Perfect.
Okay, thank you so much. Good afternoon, ladies and gentlemen. I'll give you an update on Vanishing White Matter. It's my pleasure. And I thank the ELA for inviting me. And as you know, Vanishing White Matter is also called CASH. This is the contents of my talk. I will give you a brief introduction of the disease, its cause and its mechanisms. I'll give an update on therapy developments. Then I'll say a few words on the consortium of Vanishing White Matter clinical experts, the registry, and the contribution of patients and families. The classic form of Vanishing White Matter has its onset between 2 and 6 years, and it leads to chronic motor decline, mostly coordination problems, and the cognitive decline is much less obvious. On top of the chronic decline, there are episodes of rapid and severe decline, and they are provoked by physical stresses like infections, fever, and head trauma. Patients may live a couple of years, but they may also live several decades. At the most severe end of the spectrum are patients with an onset before birth or in the first year of life, and they have a very severe disease, a devastating disease. They have little or no development. They have severe epilepsy, irritability, and they die typically within a couple of months. At the mildest end of the spectrum are patients with an adult onset, and they mostly have cognitive decline and sometimes behavioral problems. We completed a natural history study a couple of years ago on approximately 300 patients. And what you can see is that most patients have an onset before the age of 6. But that the latest onset is in the 50s. And I also know of patients not part of our registry who have an onset in the 60s. What's clear is that the onset is correlated with the severity of the disease. So the earlier the onset, the more severe the disease. For our study, we divided the patients in 6 groups, onset below 1, between 1 and 2, 2 and 4, 4 and 8, 8 and 18, and from the age of 18 on. And these are the Kaplan-Meier plots. This is about survival, this is about ambulation, and this is about cognition. And what you see is the later the onset, the longer the function is retained. If you look at disease duration, the picture becomes a little bit different. Patients with a very early onset show an immediate and severe decline, and with later onset, it becomes better. And then from the age of onset of 4 years on, the rate of the disease progression is the same. The exception is cognition, and declining cognition is early and severe in patients with adult onset. These Kaplan-Meier plots look like very reliable disease scores. Well, the effect is different. These are the individual cases and the spaghetti plots about their disease scores, and what you see is a huge variation. Only the very early onset patients have a rather reliable disease scores, but after this is already with an onset between 2 and 4, and you see some patients pass away immediately, and some patients live to in their 40s. And then still it looks like reliable for single patients, but this is also not correct, because this is just these straight lines are due to the fact that we have only very few measuring points. But if you look at individual patients, the picture becomes different. This is a patient who was declining and then all of a sudden died. And this is a patient in which we had multiple Hui inventories. And what you can see is that the disease is going up and down. And that's actually what parents of patients with vanishing white matter see, that the disease course is going up and down. And that means that vanishing white matter is extremely variable and highly unpredictable in its course, making therapy development difficult. MRI typically allows the diagnosis. These are horizontal T2 weighted images. These are flare images. And what you see is that the cortex looks light gray, that normal white matter is dark gray, and that fluid is white on T2 and black on flare. In vanishing white matter, the white matter is abnormal from early on and stays abnormal in T2, but T2 is not able to distinguish between CSF in the ventricles and abnormal white matter. Flare is able to do that. And so what you then see is that initially the white matter is abnormal but present and then turns into fluid. And in the end, there's our ventricles and there's then nothing, this cystic white matter and then cortex. We confirmed this at autopsy and you can see here the big holes in the brain. That's why we called it vanishing white matter. The cause of vanishing white matter is a defect in EIF2B, and with that it's in translation initiation. As you know, DNA determines the characteristics of a human being, the color of the hair, the color of the eyes, the height of a person, how smart a person is, and DNA does that by expressing itself in proteins. DNA is transcribed into mRNA, and mRNA is translated in proteins. That's how the code works. And you can see here our factor EIF2B, and EIF2B is conditional for translation. Without EIF2B, there's no new protein formed, and that means that there's also no life. In patients, the activity of EIF2B is reduced because of the mutations, but there's always remaining activity to guarantee protein synthesis. The second function of EIF2B is to regulate the rate of protein synthesis. So if EIF2B is highly active, there's lots of protein synthesis and there's growth. In stress conditions, protein synthesis needs to be shut down because protein synthesis takes a lot of energy, and during stress, the body has to do something else, recover. And then EIF2B is the factor down-regulating protein synthesis. So EIF2B is also very important in stress conditions. And this is what we call the integrated stress response. You see here the stressors: fever, viral infection, trauma, amino acid starvation. They all lead to phosphorylation of another initiation factor, EIF2. And when EIF2B2 is phosphorylated, it tightly binds EIF2B, in that way inactivates it, and then protein synthesis is shut down. That's not the only effect. The second effect is activation of the ATF4 response. And this is a very important response because it's going to decide whether the cell is going to be repaired or if the damage is too much, the cell is going to die. Now, in vanishing white matter, EIF2B activity is always down because of the mutations. And that means that the cell feels like that's always in stress. We have looked at protein synthesis. We cannot find that there's anything wrong with protein synthesis. And most likely the remaining activity is sufficient to guarantee protein synthesis. But the ATF4 response is always activated, especially in brain white matter cells. So brain white matter cells are always in a stress condition and have to decide, are we going to survive or are we going to die? We made mutant mouse models and we gave them mutations in two genes, EIF2B5 and EIF2B4, and so we could also crossbreed them. And the clinical picture of the mice is very similar to the human disease. They have ataxia, they may have seizures, they live shorter, and their brain pathology is similar to human vanishing white matter. So they are great models for research and for testing drugs. If you now come to think of treatments, then you can see that all the factors that activate the integrated stress response are also the factors that lead to those episodes of rapid decline in vanishing white matter. So they need to be avoided. There is already activation of the ISR, and apparently they lead to hyperactivation and need to be avoided. So fever, infections, and head trauma need to be avoided. And if you do that, that really ameliorates the disease. We have fewer episodes of rapid decline, but the chronic decline is unchanged. Other treatment options. Reduce ISR activation, for instance, working on endoplasmic reticulum stress. Stimulate eIF2B activity directly, because it's reduced with mutations, and perhaps you can increase it. Stimulate it indirectly. I'm going to show you how that works, or reduce effects of abnormal ISR activation and do something about the AGF4 response. Guanabens is an old alpha-2 adrenergic antihypertensive drug. It has FDA and EMA approval, but it's no longer used or produced by any company. It's off the market, I think, because it's not very effective. It's safe in chronic use in patients from the age of 12 years on, and its most frequent side effect is drowsiness, but that wears off. And another side effect is that it works on the ISR, and for us, that's the main effect. And it works through a feedback loop in the ISR, thus activating eIF2B indirectly. We've tried it in our mice, and it reduces the abnormal activation of the AGF4 response in brain cells. It improves brain pathology. It greatly improves motor function, and sedation is the only side effect, but that wears off with longer use. So it's highly promising in vanishing white matter. And that's why we started a trial with guanabens in vanishing white matter. It's an international trial. It's in Amsterdam. We include patients that have an early onset disease because it's rapid, so the trial can be shorter, and those patients have a more predictable disease course. I just showed you that a few slides ago, and that makes that we can match with historical controls and avoid a placebo group. They still have to be ambulant in order to avoid too much irreversible brain damage. If a patient is in a wheelchair for years, I don't think that any therapy is going to repair that. We have obtained ethics approval and we have funding. Guy Alba already told it, but the European Leukodystrophy Association contributed a substantial amount of money. Also the Dutch Brain Foundation, the Dutch NIH, two Vanishing White Matter foundations, and we have private donations. These are the details. We include 30 to 40 patients, disease onset below 6. They still be able to walk at least 10 steps with at most mild support of one hand. The maximum disease duration can be 8 years, and they need to live a reasonable travel distance from Amsterdam, but we certainly accept international travel. Patients are treated with the maximum tolerated guanabens dose, and that's because we found in mice that the higher we dose, the more effective guanabens is. And so we see how much patients tolerate, and then that's the dose that they get. And we give it in a single dose before sleep to avoid daytime drowsiness. We have a video interview every 3 months. Patients come annually to Amsterdam for more extensive investigations. And all patients stay in the trial, and the total trial duration is 4 years. So a patient that was entered as the first will be in the trial for 4 years, and a patient that was entered after 2 years will be in the trial for 2 years. This trial will answer safety, tolerability, and pharmacokinetics, and will also address major effects. I'm not after subtle effects. So I'm not after that the capability to walk is retained 6 months longer, something like that. And the trial will also yield new data for new clinical trials. Until now, the trial started on May 31, 2021. Then the first patient came into the trial, and it's now 9 months in. We have included 13 patients, and 1 patient stopped during the titration phase because of the trial constraints as compared to the mild neurological deficit of the child. So we have 12 patients in the trial right now and are still including. 7 are males, 5 are females. And the median age at trial entry is 8 years, and the age range is between 2 and 12 years. The disease duration at trial entry, the median is 3 years, and the range is 1 to 8 years. The minimum guanabens dose must be 1 milligram per kilogram per day, and we typically can dose higher. We have seen patients back now, and 9 at 3 months, 4 at 6 months, 2 at 9 months, and all patients do well on guanabens and have no major side effects. They go to school and they have resumed their life. None of the patients experienced a major neurological decline, like a stress-provoked episode. 11 are stable and 1 patient lost ambulation, although I must say he already did that during the titration phase and was already marginal at inclusion. And of course, we need a longer follow-up to determine the efficacy. These are the side effects. All patients, of course, have temporary side effects because we dose them up to the highest tolerated dose, and then we go a little bit back to the level where they have fewer or no side effects. The side effects are alpha-2 adrenergic effects, so sleepiness, drowsiness, dry mouth, feeling unsteady when walking, tremor, constipation, nausea and vomiting, sad feelings or moodiness, vivid dreams and nightmares, visual or tactile hallucinations. And these side effects resolve over a few weeks, and sometimes we see a transient recurrence later. Sometimes we need some extra medication like laxative, antiemetics, or risperidone, or we split the total dose into 2 smaller doses because some patients tolerate it better. We have a patent that was recently granted to us in the USA, and we have it pending in the EU. And the aim is, if effective, we go for market registration and want to make the drug available at cost price. Then there are new drugs that work on eIF2B directly and are activators. They've also been tested in mice and they are highly effective. So they're also highly promising in vanishing white matter patients. They are new drugs, so the short-term safety in healthy volunteers is known, but the long-term safety is not known. And there are, of course, 2 concerns. One is the self-stress response is, of course, a beneficial response. It's meant for the body to deal with stresses. So if you diminish the stress response, is the body then still able to respond adequately to stresses? We don't know that. And eIF2B activators stimulate also growth. Because if eIF2B is more active, protein synthesis will be up. So will there be an increased risk of cancer? We don't know that. These trials will start in 16 years and older, and then soon followed by younger patients, but they still aim at a different age group than the guanabens trial. Other options under development are, we are looking at chaperone molecules to reduce protein misfolding stress. Of course, we would like to use a guanabens analog that lacks the alpha-2 adrenergic side effects. You could think of 7-1. We've tried 7-1 in mice and it doesn't look good. And then drugs modulating eIF2 alpha phosphorylation and thereby impacting eIF2B activity indirectly. They are possible. Drugs impacting mitochondrial function have been found by Dr. Elroy Stein, and we are looking into them. Then you could think of antisense oligonucleotides to reduce ATF4 or downstream components of the ATF4 response, and we are also working on gene therapy. There is an explosion of therapeutic possibilities in vanishing white matter, and that's of course a wonderful thing, but it's also a problem. The problem is that vanishing white matter is ultra rare, and we cannot have so many trials at the same time. So we formed an international consortium of vanishing white matter clinical experts, and we want to facilitate as a group trials. We want to test multiple drugs in adequately powered studies, and we want to do that in parallel so that control group can be shared to minimize patients on placebo. And for this, we are developing a core trial protocol and speaking to companies about it. Then the Vanishing White Matter Patient Registry, we started it in 2004, and it's extremely important. It provides natural history data, like the Guanabens study is an open label study and uses patient data from the registry as controls. It facilitates identification of eligible candidates for the different trials, and it facilitates important studies that are indispensable, like validation of outcome measures or burden of disease trials. We, as I said, already have a registry that we formed in 2004, and it's Castor-based, so it's internet-based. And we want to change the governance of the registry, and that's in process. And we want to make the data available to also other researchers and industries. And we want the governance to be under the Vanishing White Matter Consortium. And we want also representative organizations for patients and families to be involved. And we are currently speaking with EMA and FDA about their approval. Then patients and families. What do you need to do? Very important is teamwork. So patients and families need to be active participants in research and getting trial readiness performed. So all patients and families with Vanishing White Matter or CASH are invited to participate in the International Vanishing White Matter Registry and fill in the regular questionnaires and participate in important studies like burden of disease inventory and endpoints. If needed, they need to participate in advisory boards and monitoring boards, and of course, something that ELA is very good at, help fundraising. This is my last slide. I would like to show you the trial team. As you can see, we were corona-proof. And a very important person I would like to point out, Renate Verbeek, is the trial sub-I. So actually, she does all the work for the trial in daily life. Marije Voermans is the trial coordinator, so she makes all the arrangements. And Claire de Koning is the trial nurse. And then we have a whole team working on Vanishing White Matter and the trial. Thank you for your attention.
Thank you very much, Marjo, for this such educational presentation. The next speaker this afternoon is Annette Blay, who's going to talk about Canavan's disease.
Can you see my screen?
Yes.
Good.
You can see your screen, but you don't see you.
Oh, you don't see me.
Okay, now we do.
Okay.
Yes, perfect. Thank you.
Okay. Yes. So thank you. Thanks to ELA for inviting me. It's my pleasure to talk about Canavan disease, and
we don't hear you very well. I don't know if there is an option for you to increase the volume of the microphone.
Maybe like this. Maybe is it a little bit better like this?
No, it's a little faint, but we'll have to be very quiet.
Try. Oops. Should be loud. I try to speak very clearly and loud.
Okay, thank you.
Okay. So thank you for inviting me. I will talk about Canavan disease, and the title is Care and Study. I try to go forward. Hang on. Just work. Now, these are my disclosures. We are supported by some pharmaceutical companies and different research and patient organizations. And this is my agenda. I would like to quickly talk about our leukodystrophy team at the University Children's Hospital in Hamburg. Care and study is the motto. Quickly address basic information about Canavan disease, talk about diagnostics and the cause of the disease, and then address research studies, and therapeutic trials. Okay, so what do we do in the Children's Hospital in Hamburg-Eppendorf, the Kinder UKE? We have a clinic for all leukodystrophy patients. We see patients from all over Germany and from some neighboring countries, even from some more distant countries. We offer a second opinion service to families, to primary caregivers, pediatricians, other hospitals. And our aim is to prevent and to milden the burden of disease, and to treat the patients as good as possible. So we are trained in palliative care, which is still one of the most necessary parts in the daily care. We offer specialized diagnostics. We cooperate close to our metabolic lab, and whenever possible, we offer individual treatment trials, or we are part of other therapeutic trials. The aim is to improve the situation and the quality of life of leukodystrophy patients and their families. This is just a picture of the network as we see ourselves standing by the patient and his family. The dark blue oval headlines are the departments in our university hospital, and we tightly cooperate with many of those departments, like the pediatric stem cell department, other departments as pediatric orthopedic for preventive things, and also for institutions or pediatricians outside our hospital. And of course, we cooperate internationally with leukodystrophy clinicians and researchers. Okay, so for all leukodystrophies, there are some trials that we work on, like collecting data about the natural causes of the leukodystrophies. We have a database for that. We are involved in improving MRI technique. We work together with colleagues from the Great Ormond Street Hospital in London, and try to establish myelin sensitive MRIs as myelin water imaging, or QSM. A group here of our neuroradiology department is working on artificial intelligence to establish MRI pattern recognition for leukodystrophies, and we tightly cooperate with our metabolic lab and newborn screening lab, who prepare pilot studies for leukodystrophies. The last 2 points are specifically addressing Canavan research. We are supported by the German government, and we are working in a research cooperation with the University of Braunschweig and the Helmholtz Institute in Munich, and we analyze the NAA metabolism and have a specific focus on peripheral manifestations of Canavan disease and NAA pathology. And some sub-projects there are to quantify NAA in dry blood spots. That's something that will be needed if newborn screening is necessary. We just started with the project characterizing peripheral immune cells via FACS analysis and single cell sequencing. And all of these and some other sub-projects, all of these data, all of these results are used by the Helmholtz Institute in Munich, and they use those data to create a model about the NAA metabolism. The second project that we support, or that we are part of, is a natural history study for Canavan disease that's done by the company, the pharmaceutical company Aspa Therapeutics. They are involved, or they offer a gene therapy. I will say a few words later about that. And so because the PI who's doing the gene therapy is Bernd Eichler, he's at MGH in Boston, so we have tight cooperations with him. Okay, some basic information about Canavan disease. Canavan disease is a rare and fatal autosomal recessive leukodystrophy. It causes spongious degeneration of the brain white matter, and it's leading to progressive loss of neurological functions. It also causes macrocephaly and very often premature death. The incidence for most patients, is unclear. We know that in the Ashkenazi Jewish communities, there's a much higher carrier and frequency. And the cause for Canavan disease are two pathogenic variants in the ASPA gene that lead to dysfunction of the enzyme aspartoacylase. And this causes that NAA is not split into aspartate and acetate, which causes that NAA is elevated. And it's thought that impaired brain osmolar homeostasis causes water inflow and then leads to the spongious appearance of the brain. You can see there in the right down or lower corner, the brain has a swollen appearance like a sponge. Okay. So diagnostics. To diagnose Canavan disease, usually if there is the easiest is to look at the urine, because it's easy to access and it's not a expensive investigation. And you find high NAA levels in urine, and they, which is pathognomonic for Canavan disease. You can look at the ASPA activity in fibroblasts, but this is not very common and not regularly done. What we regularly do, and others do it regularly, is the confirmation of Canavan disease genetically. So you find two pathogenic variants in the ASPA gene. Of course, clinical findings as macrocephaly and developmental delay and others that I will address in the next slides are important to start with all that diagnostics. And the MRI shows typical changes of the brain white matter and other structures. And if you do a MR spectroscopy, you see very high peak of NAA, which is also pointing to the diagnosis of Canavan disease. Okay, so cause of Canavan disease. A typical Canavan child is born after a normal pregnancy, nothing abnormal in the neonatal phase. The babies start, or the families or the parents notice at first at the age of sometimes 1 week, 1 month, 2 months, 3 months, that the child is not gaining further developmental milestones. So the developmental delay is the first symptom. Then many of these children show a floppiness. They have, especially in the trunk, they have a very low muscle tone. Sometimes in the beginning in the extremities, the arms and the legs as well. But there they often then show a higher tone in the extremities, the spasticity. There are abnormal eye movements that the family notice, sometimes in nystagmus. Many of these children are irritable. They show a startle reaction if you for noises. They are more reactive than healthy children. Yes, and feeding problems occur, and vision problems. some even have at the younger age seizures, but this is something usually that's coming later. Okay. Last year we published the analysis of 23 Canavan patients, and when we described that, we found that at a median age of 2 months, the onset of the symptoms happened in that cohort. The developmental milestones that were reached were it was only a few milestones that were reached. All patients that we know of are able to hear, but all or most of other functions are not. It's something that most patients don't gain. So, for example, visually tracking is something that about 50% learn, and almost half of that loses this ability again. Only 25% of these patients gain some head control. Yes, most of the patients do not learn to speak. Most of the patients do not learn to sit independently. So they are very severely affected. One physiotherapist once said, many Canavan patients are able to do less than a newborn because they have such a big head during the course of disease, and they have the hypotonia, and they are not really able to lift the head even if they are lying on their tummy. So it's they are quite severely affected. I have to mention that this is the typical Canavan patient. So we know some, and we are aware of more kids with Canavan disease who have significantly milder causes of this disease. They have the proof of the Canavan disease, but they still make major developmental milestones. They learn to walk, they learn to talk, even if they are not normally developed. But there is a variation, a broad phenotype for this called atypical Canavan cases. So back to the typical case with Canavan disease. During the course of the disease, most patients, about 95%, develop spasticity. Very often there is a medication needed, physiotherapy is needed, and orthopedic supplies are needed to help here and prevent consequences or side effects. There are dystonic hyperkinetic movements observed. Seizures develop during the course of the disease. We saw that over the first 10 years, almost all patients in the end suffer from seizures, and the number of seizures is getting more over time. Okay. The survival, despite earlier publications or very early publications where it was said to be a very short life expectancy, we see that almost 75 or 3/4 of the patients reach the age of 10 years, and 20 years we saw that 50% of the cohort that reached that age. So all or most patients, many patients, suffer from additional gastrointestinal problems and pulmonary problems as well. This is something that we see in other leukodystrophies as well. It's not very specific. The need for medication for all these problems and symptoms is there, and they take multiple medications. Okay, this is just a graph showing the development of the macrocephaly. The children with Canavan disease are born and have not a macrocephaly in the beginning, but you can see here, this is here the age in years when they are 1 year old, and this light gray curves here are the normal healthy children who are compared with the dark lines here, which are the Canavan patients, male and female. You see that within the first year, the head growth is too fast and crosses all the normal percentiles or the normal lines of head growth. And then at least at the age of about 18 months, almost all children with Canavan disease that were included in that analysis developed a macrocephaly. Okay. In this analysis that we published last year, we tried to establish a score, the Canavan disease rating scale that should get used or shall be used or is used to address the severity of Canavan disease, and some symptoms and signs like seizures or floppiness, spasticity, macrocephaly, and feeding problems, and so on, are addressed and are given points. And in the end, it shall support differentiation of the severity of the disease and supporting trials and gene therapy trials and other therapeutic trials. Okay, so these are the research trials that I mentioned shortly before. So the Federal Ministry of Education and Research of Germany is funding this research cooperation with Helmholtz Center in Munich and the Technical University in Braunschweig and us. And we want to understand the pathomechanism of Canavan with a special focus on peripheral manifestations. There were publications in the last year that ASPA mutations take place in cancer metastasis. That was it's not understood what this means. There were other publications in Canavan mouse models that in renal cells or in immune cells there are different findings to healthy mice, and these things we address or want to address in this research project. Yeah. So patients consent and data are entered, and cells and of patients or mouse models are investigated with different methods. So yes, I mentioned it before. In the end, all of these results are used to build a predictive mechanistic model of the NAA metabolism. And we are right in the middle of this project, and don't have too many results yet, but it's still a lot to do. Okay, another research project that we are supporting or we are part of is the natural history study Can Inform by ASPA Therapeutics. It's meant to be shall be the control group for the gene therapy trial that's also recently started. Every Canavan patient can participate, even data or information of deceased patients can be used for retrospective analysis, and there are no costs for the families to participate. But still, it's we know that, and the families know that it's some effort to take place and to give the information. Okay. So this is the gene therapy that ASPA is offering with the open center is at MGH, as I mentioned before, in Boston. They use a AAV9 vector, and it's the vector is given intravenously, which may also address peripheral manifestations that we only guess until now and are not sure what it means. But still, yes, it's administered intravenously and shall prevent that the disease is progressing and should milden the phenotype of the disease. That's the aim. But in this first phase, of course, Safety is the main aspect. And yes, the study is open for enrollment. The age for the children that may be included is up to 13 months, and they shouldn't be too far progressed in the disease. And yes, whoever is interested here can contact the company or one of the centers who are working with ASPA, as the MGH in Boston or center in Hamburg. Okay, and this is just my last slide, or almost last slide. There are other trials ongoing. There's a lot of other research ongoing. I just picked out two because it's important just to mention it. There's another gene therapy trial open since last year as well. It's another vector. It's not administered intravenously, it's administered intracerebroventricular and located in Dayton. You can look it up at the clinicaltrials.gov website. And other research is ongoing, preclinical research. One interesting finding already 2 years ago published is that in the mice, the antisense oligonucleotide that reduces the production of NAA could reverse some of the symptoms and pathology in Canavan mice, which is an interesting one and important finding, maybe for the future. Okay, this is just a summary. Canavan disease is a rare and severe neurodegenerative leukodystrophy. Hallmarks are developmental delay and the progressive macrocephaly. There are luckily ongoing research projects and ongoing gene therapy trials. My last slide. I want to thank first the families who are so much engaged and supportive, and thank my team who is very engaged in bringing these things forward, and yes, the ELA for organizing this, and I'm happy for questions to answer questions. Thank you.
Thank you, Annette, for the presentation. I'd like to ask the next speakers to please stay to the schedule. The presentation should be no longer than 20 minutes because indeed we're running a little bit late. The next speaker is Ellie Hall, and she will talk about mini brains.
Okay, thank you. Can you stop sharing your screen, Annette, please? Thank you. Can you see my screen? Now you can, I think. You see my screen?
Yes, yes.
Yeah. Okay, thank you very much. I would like to thank ELA for inviting me at this meeting, which is also very important for me to interact with the patients and their caretakers. So I'm a biomedical scientist working in Utrecht. This is just a few pictures of our beautiful cities with, of course, a lot of bikes in the Netherlands. And I'm working at the University Medical Center in Utrecht, where we built over the last year. So this is the building where we're working, and we have a special lab that we built where we can make mini brains. And I would like to show you what the potential of this new technology is for many different brain diseases, including many of the diseases that are also talked about today, but also yesterday. So this is kind of a breakthrough new technology which enables us, so the researchers and also the clinical doctors, to make better models, or at least more specialized models for to mimic the mechanisms that are happening in patients' brains. I'm very careful about this. I think you noticed that, because what we will do is we can start with skins from people with a brain disease that is caused by a mutation, a genetic mutation. And we can make from these skin cells, we can make stem cells, and then we can make mini brains again. But of course, this is not the same as a brain of a mouse, because a mouse is a fully functioning body. And now we have an isolated brain. But in certain cases, these type of models are very important because you're more closer to human tissue than if you study the mouse. But in certain instances, you still need the mouse experiments, and they are also really, really important for the progress of understanding all these different diseases. So with the new technologies, we can start with skin or blood cells from patients. Then we can repair the gene from the same patient, and then we can make a model in a cell culture dish of either a diseased mini brain or of one that is repaired because we could repair the mutation. And I'll give you an example of Alexander disease in my talk. So just a short introduction about this disease, which is also a rare disorder, also classified in the white matter diseases. Clinically, these patients have seizures, megalencephaly, and spasticity, and many, many other things going on. But if you look under the microscope, is also what you see here. You see these very thick clumps. And these are, again, clumps of proteins, which are called Rosenthal fibers. And these clumps accumulate in astrocytes. So that's the cell type that is mainly affected in this disease. And in 2001, it was discovered by L.B. Messing and Mike Brenner that mutations in a protein called GFAP are causing this disease. And these are almost all de novo mutations, and they are autosomal dominant. But what we still do not understand is how these mutations in this gene in the end leads to the disease. We know that astrocytes are important, as I showed you on the next slide, in the first slide. An astrocyte is one of the types of brain cells. So here on this slide, you see several important brain cells. So these are the neurons that are important for communication, and they are important for really steering our body, for instance, and also moving our legs, but also our cognition. Then we have the white matter, the oligodendrocytes, which form the white matter. So they wrap around the axons or the axons of neurons, and therefore the neuronal communication gets much quicker. Then you have the microglia in the brains, that's the immune system. But also you have the astrocytes, and they are the ones that are affected in this specific disease. And astrocytes are star-like cells, and they are really very important for healthy brain function. So they are important because they help the neurons to communicate, but they're also important because they're interacting with the vasculature and help to provide the neurons with the nutrients and energy that they need. So they're very important cells. So in these astrocytes, there is a very specific protein. So I'll go back to this slide. And this protein is called GFAP. And that is the protein that is mutated in Alexander disease. So this GFAP protein is part of the cytoskeleton, of the skeleton of a cell. So the body has a skeleton for the firmness of the body. But also each cell in our body has a skeleton, which is called the cytoskeleton. And here in green, you see the protein GFAP, which form this very nice thread-like structures through cells. So the blue dots here are the nuclei of the cells, and in green, you see the very nice cytoskeleton of these cells. In Alexander disease, this protein, so this is here depicted in the scheme, we know that there are several different mutations that can occur over the full length of the protein. And this one here at position 239 is the one that is the most common one. And if you have such a mutation, then what happens is that the network is not formed nicely anymore, but you get clumps of this protein in Alexander disease. And that's also what you can see under a microscope. Again, this is a high magnification. Again, in blue, the nuclei of cells. And here you see big green blobs. And this is really at a very small scale because we're looking at 10 micrometer, for instance, here. But you see that these are blobs of proteins in these cells, which cause problems in the brain and in the end the disease. And that's what we want to understand. So we want to understand how mutations in genes, that can be Alexander disease, but can also be vanishing white matter disorders or Canavan disease. So how mutations in genes cause diseases. And as a biologist or biomedical scientist, what we then need is a good model to study that. So you've heard several presentations now where people use mice models that you can engineer so that also the mutations in this gene is in the mouse, and then you can also look at how the mouse is behaving, but also at the brain. Another model or another tissue that you can use is the brain tissue of patients themselves, but obviously this is, of course, only present if patients and families are willing to donate the brains to brain banks so that the researchers can study that. And the cell models are now getting more and more attention because of this new technology of these stem cells that can be made from patients' skin. And this new technology is named IPS, the induced pluripotent stem cells. So this guy, Shinya Yamanaka, published a paper in 2006, which is not that long ago, about this novel technology. And he already got a Nobel Prize about this technology in 2012. And he got the Nobel Prize because this technology really is changing biomedical sciences. Because now we can make from every person, if we want, and if it's interesting, we can take a little bit of skin with a biopsy needle, and we can make these skin cells back to the embryonic state. We can reverse them into history. And then if these skin cells are reversed back to stem cells, we can make any type of tissue that we want in a dish. And you can imagine that that is important for several different diseases, including brain diseases like Alexander disease, but also people are using this, for instance, for Alzheimer's disease. A second breakthrough, which came in 2013, so almost 10 years ago, is that scientists showed that if you start with these stem cells, and if you add specific factors in a cell culture dish, you can grow mini brains. Because also during development, the brain and every body in the tissue is differentiated or comes from stem cells that are dedicated to make brain cells, for instance, or stem cells that are dedicated to make tissue, to make skin cells. But we can make now mini brains in a dish. And that is going like this. So again, we start with either a little bit of skin or a little bit of blood. We can add some DNA factors to that in a cell culture dish, which is called reprogramming. And these cell types go back to the embryonic stage. And that's called induced pluripotent stem cells. These stem cells we bring in a cell culture dish on day 0. We give them very specific cell culture medium with all kinds of growth factors. And then on day 6, we culture them in specific plates, so that they come together and form mini embryos, embryoid bodies, we call them. So that's what you see here. So this moment, this piece of tissue can become any type of tissue in your body. So also muscle, but also brain. And then we add specific factors, and then we induce mini brains formation. And you see that these cells are becoming rounder and start to become as big as a green pea. And if you look under the microscope, you will find back everything, almost everything that you find in a developing brain. And that's why this is so interesting for researchers to study. So this is how they look. So this is normally 6 centimeter dish, and you see that these brains are lumpy, roundish structures. And under the microscope, you can see all kinds of different structures, which I will show you in a minute. And these 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 dishes with mini brains, we have to put them on a shaker so that they do not clump together, but also that they get sufficient nutrients from the cell culture medium. We call this a belly denser. Under the microscope, you can look at all kind of different things in these mini brains. So here, all these red dots are all kind of cells that are still dividing, because this is the developing brain structure. And here on the right side, you see different colors, green and red and blue. And the green and the red are the different layers in the developing cortex, so during neuronal development. So we use this technique to start to study Alexander disease. And in Alexander disease, there's a protein called GFAP, and there's a mutation here at position 239 that is very well studied. We contacted 2 researchers from the United States, Jan Hongxi, but also Natasha Snyder, and both had made already iPSCs from a Alexander patient. And we got these cells from the United States, and we started making mini brains from them. So we started doing that in 2020. It was from one patient, and these cells were in a biobank and were also available for research, and there was informed consent. So the parents gave consent to perform research on the patient's cells. It was a male patient with a very early onset of the disease. And we had control cells that were engineered with CRISPR-Cas, or repaired with CRISPR-Cas, and Alexander cells. And this is the first data that we have, and I only have a few more slides. And this was the first thing that we saw. After 10 days in this culturing system, we saw that the controlled cells of the patients, the repaired cells of the patients showed very nice mini brains, and the Alexander patient mini brains, they crumble a bit. So they stayed small in our culture. We still do not fully understand what's going on there, but something with the differentiation, we think. And under the microscope, we see this. So if we wait a bit longer, and the one of the brains that do not crumble but that do survive, what we see under the microscope, so the top layer is from the Alexander condition, and the layer below is the control. And what you see, for instance, is that there are more cysts with more fluid in here in the Alexander case in comparison with the control. And we see also, for instance, in TUCH, one is neuronal differentiation. There's much more here on the inside of this fluid-filled structure. We have to do much more research for this, because it's quite research that takes quite some time. And we also want to grow these mini brains up to 1.5 years, but many of them do not survive, and most likely because of the phenotype. But now we have several indications that something is happening with these mini brains during development. So our current questions are, so why are these mini brains in our research so small? What is happening with the differentiation? Then we want to know, if we zoom into these mini brains, what is going on with the astrocytes, because these are the cells that are in the patients are mainly affected, or at least there is the mutated gene expressed. And we would like to know whether we can prevent the phenotype. So can we give some medication to the cell culture medium and see whether we can prevent that these mini brains stay so small in our case? This research is part of a larger consortium which is funded by the European Joint Programme for Rare Diseases, and ELA is one of our partners in here, together with the Dutch VKS, which is the Dutch organization where also the white matter patients are part of. And in our consortium, which is European, we study these mini brains, but also neurons and astrocytes in 2D cultures. We look at all kinds of changes in RNA. We make a novel fish model. I do not have sufficient time to explain this, but fish are very important models to study genetic diseases. and we look at protein level with a Spanish colleague. So these are the main consortium members. From Sweden, Milos Pekny and Henrik Alenius. From Prague, or the Czech Republic, it's Miguel Kubista. From Israel, Itamar Harel, who's making this new fish model. From Spain, Dolores Perez Sala, and Werner Dijkstra is the PhD student working in my lab on the mini brains that I showed you. And we recently got additional funding for our project from like CAIXA, so that we can extend the work that we started 2 years ago on the European fund, which will run for another year, but we're actively looking now to be able to extend our research. So I would really like to thank you for your attention, and I hope that I've shown you that several different models are needed to be able to understand why certain mutations cause these diseases, but also to have models so that we can screen for novel drugs for the future therapies. Thank you very much.
Thank you very much for this nice presentation. The last speakers of the session, the first session in the afternoon, is Angela Gritti and Vasco Meningini, who will talk about Alexander's disease.
Okay. I see the screen.
Yes.
Okay, so good afternoon to everybody, and I really thank ELA for inviting us to this meeting. I'm here with Vasco Meningini. We are working in Milano in the San Raffaele Teleton Institute for Gene Therapy, and I'm happy to give you an update on the project on Alexander disease that is ongoing in the lab. So, Alexander disease, we already had the very nice presentation. So, it's a primary disorder of astrocytes. It's caused by gain-of-function mutations in the gene for glial fibrillary acidic protein. And this leads to accumulation of the protein, aggregation, and a response, a reactive response in the astrocytes. And this has a severe effect on the central nervous system. There are still many aspects of the pathology that have remained unclear, particularly the initiating events in the accumulation of the protein in the pathology, but also the relationship between astrocyte dysfunction and myelin defects, for example, and the variability in the age of onset, the disease severity. So we have just seen that these novel human-based models might answer to some of these and clarify some of these issues. But from the therapeutic point of view, the most straightforward idea in view of therapeutic approaches is that of reducing the amount or eliminating the production of the protein that initiates the disease process, so GFAP. And the possibility is to achieve a sort of generalized suppression, so reducing both the mutant and the normal GFAP, which are present, of course, together in the disease. And this is the mechanism of action of antisense oligonucleotides, which interfere with the production of the protein at the level of the messenger RNA and effectively suppress the expression of the protein. And this approach has been tested in mouse models of Alexander disease with good results, and now this is currently under clinical testing in patients. So what we are proposing is an alternative approach, a different approach that might be alternative, and this is based on state-of-the-art gene editing technology. So this approach employs an enzyme that is called Cas9. This is able to cut the genomic DNA, but this is a sort of art-specific cut. So we need to couple this Cas9 with a guiding system that we call a single guide RNA, which provides specificity. So in other words, we can design these guides in order to match specifically the portion of the DNA that we want to cut, which in our case is the gene encoding for GFAP. So these breaks in the DNA strands are not faithfully repaired, so this results in a stop signal that hamper the production of the protein. So using this approach, we should be able to obtain a stable downregulation of the protein, which should be compatible with the idea of one-shot treatment. And importantly, since we can design specific guides, we should in principle be able to discriminate between the mutated and the non-mutated GFAP instead of suppressing both. One of the main risks associated to this system, to this platform, is to have undesired targeting of other genomic sequences that display high similarities, for example, with the target sequence, so the GFAP that we want to cut. And this may result in what we call off-target effects, off-target breaks that may lead to genotoxicity. So based on these premises, we have a project in the lab, ongoing in the lab, and the long-term goal of the project is really to develop a definitive one-shot therapeutic intervention for the treatment of Alexander disease, based on this Cas9-mediated downregulation of the expression of GFAP in astrocytes, which we know are the relevant cells that are involved in these diseases. So the project is in the pilot project that is funded by ELA. Our aims are to set up the reagents and the tools to do this, and of course to provide proof of concept validation of these reagents using in vitro models of the disease. So the project is led by Vasco Meneghini, the project leader in the lab, and of course he will be here and participate to the discussion. But now I just very briefly show a summary of the main results that we have obtained so far. So first of all, we have generated cell models that express either the wild type GFAP, the normal GFAP, or the GFAP. Sorry, I hear an echo. Okay, I lower a little bit the volume. So either the normal GFAP or the GFAP that bears the two most common mutations. We are talking about the murine genes in this case. We generated lentiviral vectors that carry this GFAP protein, the wild type or the mutated, but linked with this red fluorescent protein that we can detect using a dedicated machines. So we start from fibroblasts. So these fibroblasts that are not transduced with this vector are not red, and they cluster here in this plot. You see here, while the fibroblasts that that have been treated with the vector, so they express this M-cherry protein, so they are fluorescent, they express red fluorescence, and they start to appear here. And as you can see, more or less 90% of the cells that have been transduced with the vector display this red fluorescence. Sorry, I have to turn down the window. Okay, I cannot do this, no problem. Okay, so this is a sort of detection system. So how to detect the wild type or the mutated protein just using fluorescence, okay, and a simple machine. Of course, then we wanted to use these bright red cells to test the efficacy of different Cas9 and guide system to silence the GFP expression. So the idea is that if we deliver the Cas9 guide system that disrupt the expression of the GFAP, we should see a decrease in the percentage of bright red cells. And this is exactly what we observe when we deliver transiently this Cas9 system in fibroblasts. You see at the beginning you have 90% of bright red fibroblasts, and after the treatment, this percentage goes down to 50%. So meaning that this system, the detection system works. So the next step was to design and select specific guides, RNA, that could target either the normal or the mutated GFAP genes. So we tested several guides in combination with the Cas9, and I just show one example of this guide number 8. This recognizes a sequence of the GFAP that is far from the mutation. So in principle, should be able to suppress the expression both of the mutant and of the wild type protein. And this is exactly what is happening. Again, this is only the mutant, but it's the same for the wild type. So you see a reduction in the percentage of bright red fluorescent cells. Okay, if you deliver this system. So. And this is true for the wild type and the mutant, but we can also design, as I said at the beginning, specific guide RNAs discriminating between the wild type and the mutant. And you see here an example, this guide number 10 specifically recognize a sequence of the mutated GFAP. And so if we deliver this guide together with the Cas9 in cells that overexpress these mutated proteins, you see a downregulation again of the percentage of red cells in this case, but not in this case. So not if you deliver the same system to cells that express the normal, so the wild type gene. So meaning that there is a specificity for this mutation. And the same is true if we change the guide. This time is specific for the other mutation. And again, you see here a downregulation of the percentage of bright cells, while the cells that express the normal GFAP remain minimally affected. So all these data tell us that our system can discriminate between the normal and the mutated gene, but are we sure that we do not induce breaks in other regions of the DNA, so not the GFAP gene, so what we have defined at the beginning as off-target effects? There is a way to check for this based on the similarity in predicted sites, based on the similarities of the DNA sequence. And just to summarize, so our preliminary data show that at least for the system comprising the Cas9 and the guide number 8 and the guide number 10, we have undetectable off-target activity, as you see here, while we have most of the activity on target, so in the GFAP gene. So with the proof of concept that this gene editing system may work to silence the GFAP expression specifically if delivered transiently to this fibroblast. So we are now moving on testing whether this system is similarly effective and safe when delivered to astrocytes that express either the normal or the mutant GFAP protein. And in these experiments, we would like to use adeno-associated vectors to deliver the Cas9 and the guide system. Why AAV? Because we have already saw before that these vectors are widely used, have a high tropism for CNS cells, and are widely used in murine models and also in human clinical trials for several CNS disorders. So to summarize, so far we have optimized the platform to efficiently screen guide RNAs that target the murine GFAP gene. We have selected the CRISPR-Cas9 systems in order to induce the downregulation of the total GFAP protein, but we also are able to downregulate specifically the mutated GFAP protein. And we have generated in vitro Alexander disease-like models in order to provide proof of concept in vitro, of course, of these selected gene editing platform. Of course, we want to analyze more in depth the off-target activity because, of course, this is a critical issue in terms of safety of the platform. And of course, what we want to do in this project is to provide, to complete the experiments in vitro on astrocytes just to test whether this AAV-mediated delivery of this gene editing platform is really working. And we believe that altogether this data will allow us to move quite fast to in vivo studies. So in order to provide proof of concept of this gene editing platform in Alexander disease models. And I have to acknowledge, of course, Vasco Meneghini for his supervision of the project and the other people that contribute to the project, Serena, Giada, and Davide, all the other people in the lab. Of course, the collaborators within our institutes and outside our institute, ELA for the generous support, financial support, and Vasco was also funded by a Marie Curie fellowship to perform this project. And I thank you for the attention, and Vasco and I will be happy to take questions.
Thank you very much, Angela, for such an interesting presentation. I'm going to ask all the speakers in the session to show their to set up the video. Okay, perfect, and the microphone. So we have some time for questions.
So at this time, we invite the families who wishes to raise their virtual hands, and then we will ask you to open your microphone. Les familles qui le souhaitent peuvent lever la main virtuellement.
Those families who wish to ask questions can raise their virtual hand and ask questions. They will unmute the microphones when they are asked to do so. No questions? No raised hands?
Mario, if you
Marjo,
there is a written question that you could answer.
Okay. But it is in French. Can you translate it for me?
Oh, that's right. She's asking what is the mode of transmission of CASH syndrome. Their son, deceased in 1997 in Paris at the age of 6 of the syndrome, but the gene wasn't identified at the time. How can they know if the brothers and sisters have the same gene? And if they can have children as well? Is there a possibility to test this before birth?
Thank you for the question. The inheritance is autosomal recessive. That means that both parents are carrier and that the patient is sort of double carrier. And I would expect if the child died at a young age, and the other children are already teenagers or adults, that they just don't have the disease. Because there's a rather tight genotype-phenotype correlation, and a patient with an early onset and then in the same family being pre-symptomatic as an adult, I haven't seen it. If they really want to know, then both parents can be tested for carriership. And if we have then identified the mutations, or another lab has done that, then the siblings can ask for testing for carriership. And if they are positive and also a carrier, then they can ask for genetic analysis in their partners. So it's still possible to confirm the diagnosis genetically and do family testing. Does this answer the question?
I believe it does. Thank you. Anyone who would want to ask a question, don't hesitate. You can click on the hand at the bottom of your screen, and we'll give you the opportunity to open your microphone and ask your question. So Claudine is thanking you for your answer in writing. No other ends? No other question? We have written question, but that is on Ekari-Goodyear syndrome that we will be presenting after the break. So no other question for the moment.
Elise, would it be allowed if I would ask a question?
Sure, absolutely.
And may I ask you, Ellie, a question? And it was a great talk. What I think, but perhaps you help me here, is a limitation of a mini brain for Alexander disease is that there is no vasculature, whereas the astrocytic end feet are typically part of the blood-brain barrier. They have the end feet on capillaries, and that's where the Rosenthal fibers are deposited. So how much do you think that a mini brain for this specific disease, because I think it's variable for different disorders, but how much it replicates the disease in humans?
Yeah, that's a very interesting question, Mario. I think it is really depending on what we're going to see. And you're right, there's no vasculature in there. I'm together with Elga de Vries, I'm trying to connect it to the vasculature, right? So we will for sure also look at that. I also have to say that we did not expect this large phenotype, but I've showed you before, we're constantly seeing it in several different lines. And one thing, I mean, now they're going to make it quite technical, but it also has something to do with some mechanotransduction, because if we culture them in a different plate, we don't get it, the phenotype. So there's something happening very early that causes this phenotype. If we knock out GFAP, the phenotype is not there. So I think that if this is indeed happening in real life, that those very early embryos most likely do not survive. That's what I think. And that the others will survive. So that's why I hope that we also are able to culture some of them a bit longer. And it's possible because sometimes we can culture them for longer. And then we see these larger ventricular structures, which are fully right. But we did not expect this phenotype. So whether it has a direct, how do you say that? Whether it direct means something for the patients, I cannot tell you right now. It does say something about how the gene is working and what is going on there. And that could have an effect in the end, of course, on that. But you're right. So we are trying to build in the vasculature as well. So that's why we really need still animal models. So there's also like a movement of people that say that we should not use them. But I think it's really, really important because there we have the full body, we have the brains, we have the interaction with the vasculature and all these IPS models, which are great, but are only part of the whole system. But thanks for the question.
There is a rat model that replicates the disease.
I know, thank you. Do you know of any developmental disorders in this developmental problem in the rat model? I've asked around, but no, okay.
All right, we have no other question for the moment. I guess the presentation were very clear.
Or maybe too complicated.
So we have some question in writing. I'm not sure to who it is addressed. It says also the specific organoids, murine animals, model, etc., need to be developed for each disease. The gene therapy vectors, mRNA targeting, and tropism issues and tech are generic for leukodystrophies. Are you working together to collaborate across diseases? This is a general question.
Yeah, if I can answer this, I think yes, we are. I think we learn a lot from each other. It's always depending on funding, though, right? Because we can only do with the funds that we have, but for sure there's a lot of crosstalk between different diseases. So I'm working on several different diseases. So I'm also Alzheimer's disease, but also Aicardi-Goutieres syndrome. I've worked on several different diseases. I'm sure many of us, not many of us, but some of us also do that. So it's technically very interesting and challenging. And then we have to translate that to the patient situation. But all of these are important in the end to work towards a cure or for the patient of the future. And then we need, of course, also the clinical trials, which are also important. But all these different steps are needed and collaboration is needed. Yes. Mm-hmm.
And to add to that, Ellie, it's true that everything needs to be developed specifically also for a disease. Like if you work on Alexander disease, you're looking for an animal model for Alexander, and that's different for the animal model for CASH or for MLC. Yep. Or so we need to do this all separately. But Ellie is right that we also learn general information. which pertains to leukodystrophies in more general. So we need to learn about astrocyte function and oligodendrocyte function. And so it's a yes and a no.
And also the platforms we use for gene therapy, for example, or for the editing of the genomes, this will work for any disease. It's just a matter of applying it. And of course, the collaborative projects are always the most efficient.
Thank you. So we have another question in writing that I will translate as well. That's in French from Jorge Bernardino. He said he lost his child of CASH syndrome at the age of 6. And his older daughter, is also a carrier. And what should be done when she will be in the age of having children?
That's an important question. The general carrier frequency in the population is so low that the chance that the partner also is a carrier is very low. So we don't actively recommend carrier testing specifically. But if it's of course devastating to see a sibling die at such a young age. And if she wants to be sure, then she can ask that the partner is tested for carrying a mutation in the same gene. That can be done.
Thank you.
May I ask the parents a question? Because as I said it to you, Elise, last year, sometimes I feel we are giving talks and I'm not always sure that we give talks that contain the information that the parents want to know. Can the parents tell us what they really want to know so that we can focus on that next year?
Let's see if they raise their hand or answer you in writing.
Any possibility, because I think I see all researchers that are here for the parents and the families. So we really want to share what you want to know. And also, Elise, you can collect the information perhaps for us in the coming days and share it with us.
Mm-hmm. Yes, we can. Okay, so I'm going to give the microphone to Patrick Winters, who volunteered and raised his hand. So you can now open your microphone.
Hi, thank you for the question. Can you hear me?
Yes.
Absolutely.
So apologies, I'm short of breath. I've been working outside while listening. So to answer your question, I think what you presented today is very important. So I work on behalf of the Aicardi-Gouttiere Syndrome Americas Association. So we're the advocacy group. And I see what you're doing, or perhaps I see our role as translating some of the scientific information and knowledge for families that might not have the scientific literacy. So I think that's our role. I say continue what you're doing, present in specific terms with as much information and knowledge as you can present. And then we translate that in however we can to something that everyone understands. But it does a number of things for families. It inspires hope. It rallies us to organize. It's encouraging. It's encouraging for everyone that wants to see us making progress on these diseases. So thank you.
N'hésitez pas à lever la main pour poser vos questions.
Do not hesitate to raise your hand if you want.
We have a question in writing.
To ask a question.
As a parent, we are waiting to see where your research are going, and what you have done. And because of what you're doing, it's more of a comment. Because of what you are doing, we are keeping hope. That's their comment.
Well, thank you so much. And I hope that my message also came through, that we need to be a team with the parents and the families. I heard multiple people talk about, also, for instance, Annette Blij, about how we need information from families. So it's also a question, let's be a team.
There is another question also that I will translate. A parent comment that says that, of course, we cannot surely understand everything that are very technical that you present, but it is good and just that you're saying them, because you understand them and then you work at them, and so it's good for us. Someone said that the information you have given in relation to the diseases are very good, and that allows us parents to see the evolution that you're bringing to your research, and that gives them hope also. Fairly similar comment.
I think it's nice to hear that what we're doing, that the parents like that. I can also understand that sometimes it's really very technical. And for me, for instance, I'm always in the lab. I'm not a doctor, so I do not talk to patients, and I'm more than willing to explain. But it's, and I think also this online is really great. But if I have people in the lab and guiding them around the lab what we're doing, it's a bit easier to explain. But I'll do my best, and I think it's at least nice to get some feedback. I think we're all willing to. So we're not here to show off how good we are, right? We are here to really show you what is the progress. And what we are trying to do to understand the disease so that patients can be helped.
More questions?
So no more questions now. There's a comment. It's in Italian. We'll see if we can translate that. Daniela Mili has a daughter, 35-year-old, and she says only time is missing, and that maybe we will not be able to see the results, but it's important that it's important for everyone that the work goes on.
Thank you.
Others are really thanking the researchers a lot for what they're doing.
I would like to thank the families for the confidence also and the support. This is also touching for the scientist.
And if I may add a comment, most importantly for those research projects that are at the very early stages, let's say, of basic research or methodology like the organoids or gene editing. So, of course, if I would be a parent, I would like to hear something, more towards the translation. But of course, we all know that it takes time, and so we are really. I really have to thank the parents and ELA and the association for the support that they give also for the projects that are the very early stages. So far from a treatment. So that's very touching again. So I really have to thank all the parents and the organization.
Thank you. I don't see any more questions. I think maybe we reached the end. If there is additional question later on, then maybe we will be able to relay them in writing to the researchers.
Okay, thank you very much. I'd like to thank you, the speakers, also for such interesting session.
Thank you very much. I think we'll go in. We'll have a short break of 15 minutes, and we'll see you then. Thank you very much.
You're welcome.
Bye bye.
Hello, everyone. Hello, Yannick, and all our speakers.
Hi.
Thank you for joining us today. Hello, everyone. I think we can, if everyone is ready, I guess we can speakers start. And Yannick, I'll let you start. Joining us today. I think we can, if everyone is ready, I guess we can start. And Yannick, I'll let you start.
So, Elise, it says I can't share my screen.
Yes. I have this. Go ahead.
Okay, thank you. There we are. So, Elise, it says I can't. Okay, so can you see that?
Yes. Yes, absolutely.
Okay, so thanks very much to Elise, Helen, and Guy, and Ella, and okay. So there's a mixed session today or this afternoon. Okay, so and I believe that we've all got 20 minutes or so to talk, and then there'll be questions at the end. So I'm sorry that we're not meeting in person, and it's a little bit strange doing it this way. I'm also aware always that there are families at different stages of getting to know about. I'm sorry that we're not meeting. In particular, I'm talking about Aicardi-Goutieres syndrome. So I've just tried to give a brief overview of where I think we are. So my name is Yannick Crowe. I'm a clinical geneticist, so that means I'm a rare diseases doctor, working between the University of Edinburgh and the Institut Imagine in Paris. And Aicardi-Goutieres syndrome, for just a little bit of background, was named after two amazing pediatric neurologists working in Necker Hospital, which is attached to Imagine, in the 80s, 90s. And they described this disease that they were perplexed by because they realized it was genetic, but that it had to them, there were certain aspects of the disease that were reminiscent of congenital infection. So when children are infected across the womb during a pregnancy. And essentially, this is a disease of the brain. So these are some MRI scans, and we often see changes on the brain scan which are really quite give us a very significant clue as to the diagnosis, in combination both with white matter disease and the presence of calcification in the brain. Although I have to say that neither of these two features is necessarily always present. It's also a disease of the skin, or more generally of other organs outside of the brain. And not everybody with Aicardi-Goutieres syndrome gets skin disease, but when you do get skin disease, it's a real clue to the diagnosis. So I would say that these days, making the diagnosis of Aicardi-Goutieres syndrome in its classical form, at least, is really quite trivial, I suppose. People have become familiar with AGS, and then, of course, with the advent of new genetic sequencing, it's become easier still, and one can be much more confident of the diagnosis than perhaps was the case previously. So I've mentioned already this idea that the disease looks or can look a bit like congenital infection, like when a baby is affected because of an infection that's transmitted across the placenta during pregnancy. And I just want to point out to you, these are, I'll change my pointer because of an infection that's transmitted, and put that on. So these are levels of interferon. So interferon is a chemical that we produce as humans, our cells produce when we're infected by a virus. And effectively, interferon is a kind of disinfectant. It kills germs. And it's really quite good at doing that. But at the same time, you have it's a dangerous substance. It's a toxic substance, and too much at the wrong time in the wrong place can be bad for you. And essentially, that's what we think is happening in Aicardi Gouttier syndrome. I just want to point out to you, these are the kind of levels of interferon alpha that you see in the cerebrospinal fluid, which is the fluid that bathes the brain when the doctors take out a piece of fluid from using a lumbar puncture. So when they take a piece of this fluid out, and if you have an infection of the brain, like a meningitis or an encephalitis with a virus, you get these kinds of levels of interferon, so between 1,000, 10,000, even up to 100,000 femtograms per mil of interferon. And these are the kind of levels you see in patients with Aicardi Gouttier syndrome in the cerebrospinal fluid. So, just think about that. It's as if these patients with Aicardi Gouttier syndrome are infected by a virus, but all the time. Then this is something where the interferon is produced to kill the virus, and once it's killed, the interferon will come back down. Whereas here you see that the levels are high and are likely to remain high through a lot of the patient's life. So, Aicardi Gouttier syndrome is a what we call genetically heterogeneous disorder, and that means that although in any one patient the disease is most likely due to changes in one piece of genetic material or one gene, if you take a group of patients with Aicardi Gouttier syndrome, you could have changes in any one of now 9 genes. And the most recently added genes are these two. One's called LSM11 and one's called RNU71. And I'm not going to talk more about that, but just to say that this makes, it does make the genetic, you have to screen, you can't necessarily tell what gene might be involved in any one patient, although there are clues sometimes now that one can use to be more, predict the genetic change. But it's clearly a genetically complex disorder in that sense. There are many different genes which, when they don't work properly, effectively result in the same disease that we see as doctors, that the patients demonstrate as affected individuals. And we think that the reason for that is because all of these genes effectively, when they don't work, result in a common outcome. And all of these genes do something to what we call DNA or RNA, so our own genetic material. And when they don't work properly, our cells misrepresent our own DNA and our RNA as coming from a virus. And because they misrepresent our own DNA and RNA is coming from a virus, they produce this chemical, interferon, this antiviral chemical. So when we first started looking for genes causing Aicardi Gouttier syndrome, we had in mind a very specific idea of what it looked like, and I'm calling that classic AGS. But over time, with the introduction of these high throughput, large-scale genetic screens, we've learned that the clinical picture associated with genetic changes in any of these 9 genes is broader, wider than AGS. So, for example, we can see individuals who have no problems with thinking or talking or learning. The problem they have is what we call a spastic paraparesis, so they have a stiffness of the lower limbs, and their brain scan is normal and their spinal scans are normal. And there are other different ways in which the disease can express itself, which are sort of essentially, this is making life a bit simpler than it is perhaps in real life, everyday life. But broadly speaking, there are these different presentations of the disease, and we don't understand why necessarily there should be these differences. So you can have patients with different patients with changes in the same gene who might present with classical AGS or with this, what we call spastic dystonia, or with, if it's ADA1, with this kind of problem or with this kind of problem. And why some people present in a particular way is an unanswered question. And I just put this up to show again why we're chasing interferon as a possible culprit in this disorder, because here we have a description from a good while ago now, I think it was 2014 or something, I can't quite recall, where we found mutations, genetic changes in any one of these 3 genes at that time as causing a stiffness in the lower limbs. And I just put up the fact that in the 80s and 90s, doctors were using interferon as a treatment. And they were using it as a treatment for what we call hemangiomas, which are abnormal blood vessels, like a birthmark, and for papilloma, which are lumps growing in the voice box. And what people notice is when you use interferon as a therapy, you could actually induce a stiffness in the lower limbs, this spastic paraparesis or diplegia. And I think I just put this up to demonstrate, or as a piece of evidence in favor of the idea that interferon might be underlying Aicardi-Goutieres syndrome. Interferon is clearly a neurotoxin. It can damage the nervous system. Okay, so in terms of, we've learned stuff, and we're trying to use that information that we've learned to inform the way we try to treat Aicardi-Goutieres syndrome. Essentially, there have been two approaches that have been used to date. One relates to the use of these so-called reverse transcriptase inhibitors, which are drugs that inhibit the life cycle of what we call retroviruses. And these are actually the drugs that people use to treat HIV. And although it sounds like science fiction, the point, this strategy relates to the fact that only a tiny proportion of our genetic material codes for genes. The vast majority of our genetic information is what we call, what sometimes people call junk. But actually that junk is a considerable proportion of that, maybe 40% or something, is composed of ancient virus that we've incorporated it into our own genetic material because simply we couldn't get rid of it. These viruses are too powerful, and they've come in and they've started to live inside of our cells. And inside of our cells, they want to replicate. They want to make copies of themselves. And we think that the hypothesis, the idea, is that some of the genes involved in Aicardi-Goutieres syndrome may be involved in trying to stop those retroviruses that have been embedded in our own genetic material from reproducing. And so we've used the same drugs that are used to treat a virus on the outside, HIV, to try and treat a virus in the inside, in the case of Aicardi-Goutieres syndrome. And this was a trial that started, 2015, or maybe early, about 2015. It was funded by ELA and undertaken in Paris. And as I've said, we were using these reverse transcriptase inhibitors, these drugs we treat AIDS with. And very, very briefly, we think we saw a reduction in the amount of interferon that was being produced when patients were on this treatment. So this was encouraging, but there were problems with using these drugs, practical problems. They're not particularly dangerous, and we have a vast amount of experience with them because of their use in HIV. But we really need to do more work on this. And in the UK, we've been trying to do that, but everything's been stopped because of the COVID pandemic. But hopefully there will be a follow-up study of that approach to acardic-inducing. The other way people have been approaching the problem is by blocking interferon signaling. So I've talked about interferon already. There's an interferon molecule there, and interferon attaches to what's called a receptor. So the interferon attaches to a receptor, and that induces an interferon response, an antiviral response. And it turns out that there are drugs that can inhibit a component of that receptor, this JAK1, and there are these JAK inhibitors. And so we and others have been using these JAK inhibitors for a while now. We've got quite good, we've got quite a lot of experience with these drugs now. And this was one of the very early cases that we reported a young child with a TREX1 mutation, and you can see that she had terrible problems with her skin. And after 2 months of treatment with a JAK inhibitor, ruxolitinib, that we were using at that time, she had really quite a remarkable response. So what this tells us is that these drugs do something useful in the case of the skin, really quite remarkable in the case of this particular patient. And that's so we know that we are approaching a biologically relevant pathway in this case. We don't actually know exactly, we're not absolutely sure how these drugs are working because they don't just block JAK1. And the other kind of disappointment from my perspective is that at the level of and then this is the most comprehensive paper that's been published from Adeline van Derven and Laura Dang and colleagues in CHOP. So they clearly do work, at least at the level of the skin and other what we call systemic problems. So sometimes people have problems with antibodies against blood cells, for example. But it's less clear how well they work at the level of the nervous system. And that could be for various reasons. One is that maybe we don't use them early enough. One is that we don't get enough of the drug into the brain system. And this was something that came up and we were able to explore a little bit when we identified this child who had classical AGS presenting at the age of 4 months. And then he had a brother who was born who had the same genetic changes in RNase H2B, AGS2. And when we saw the brother at 4 months, he was unaffected. And by 5 months of age, we'd started ruxolitinib. And he didn't seem to have any problems, and he didn't seem to have any problems, and he didn't seem to have any problems. And then he developed acardic-inducing. So he developed problems that were consistent with the diagnosis of AGS at the age of 14 months. So that was very disappointing. That's an understatement. It was devastating for the family and upsetting and disappointing for us because we were really thinking maybe we'd stopped his disease from happening. And one of the issues, I think, is that when we looked at the levels of the drug in the blood, or what we call plasma, you can see these kinds of levels. And when we looked at the levels of the drug in the cerebrospinal fluid that bathes the brain, we saw these kinds of levels. So they're about 1/10. There's only a very small proportion of the drug in the cerebrospinal fluid compared to that in the plasma. So maybe this is the reason why he's still developing the disease. I think in the future, what we're going to have is rapid and earlier genetic diagnosis. We might use more than one drug. We use a combination of drugs, like people use a combination therapy in cancer, say. And we might actually need to give the drug into the cerebrospinal fluid if we really want to get high enough concentrations to protect the brain adequately. What I would say as a final slide is that there is a very considerable amount of interest in developing treatments for acardiogugissenone, and there will be other treatments, and people will want to trial them in patients with AGS. And so I think, in the US, in the UK, and in France, and elsewhere, we really need to get ourselves together to develop networks so that when these drugs do come along, we can use them quickly, or we can get them into a clinical trial situation. Now, that's not going to be completely trivial, not least because it's a relatively rare disease, and because of the variability in the outcomes, which I touched on briefly at the beginning. Then being absolutely sure that the drug is making a difference remains a very difficult, important challenge in this situation. Okay, I'm going to stop there. Elise, I hope I'm not too...
Perfect. Good timing.
Yeah. Okay, good. I'll stop. Yeah, thank you. I'll stop sharing. Great. So shall I introduce the next speaker?
Absolutely.
Yeah, okay. So it's my pleasure to introduce Tien Paul, who's, I think, emeritus professor at the Academic Medical Centre of Amsterdam, and I think has stepped in at the last minute to talk to us about Zellweger spectrum disease. So thank you.
Yes, it was the last minute. Mark Engelen was not able to present this presentation because his daughter, it's the birthday of his daughter. Well, yes, it's Mark Engelen. I will discuss the Zellweger spectrum disorders. Officially, I do not see many patients anymore, except for the Zellweger patients I see together with Mark. We have still an outpatient clinic. I will share the presentation. Except for the Zellweger patients I see together with Mark, we have still an outpatient clinic. I will share the presentation.
Yeah, that's good.
Okay. The content of the presentation will be a brief biochemical background with after that clinical feature, and very important for parents, the follow-up and supportive care. The content.
Maybe you can use the full presentation mode.
It's Shift F4, F5.
I'm not sure. At the bottom of your screen, next at the bottom right, you have right here. Perfect. Maybe you can use the full presentation mode.
Yes, it's Shift F4. The peroxisome are subcellular organelle, very tiny organelle, and were discovered in 1950. You hear me?
We can hear you, but the slide is not in full screen.
Peroxisome are subcellular organelle,
and we try.
In 1950. You hear me? This is full screen, I think.
But the slide is not in full screen. Okay.
Yeah, and now we know many metabolic functions in this organelle. There are many important human functions in this organelle. For example, including the long-chain, very long-chain fatty acid, the branched-chain fatty acids, and the synthesis of bile acids, and also the synthesis of ether lipids, what's important also for the central nervous system. and the synthesis of what I will discuss in these presentations are the Zellweger spectrum disorders. The paroxysmal disorders can be classified into two big groups: the biogenesis disorders with many biochemical defects, and the single paroxysmal enzyme deficiency. But this we will not discuss. So these disorders are caused by mutations in PEX genes, and they are very important and involved in creating peroxisomes and for the import of peroxisomal enzymes into the peroxisomal proteins. This is a very complicated schematic overview of how it happens. You have matrix proteins which are bound to peroxisomal targeting signals. You have two signals, PTS1 and PTS2. For the Zellweger syndrome, it's the PTS1. And then when it's on the receptor, it is transported to the peroxisomes, to the membrane. And there in the membrane, there is a docking system, and the protein enters the peroxisome, and the receptor ligands are recycled to the cytosol.
I'm sorry, Dr. Bolte, I don't think we see your slides moving forward.
We're still on slide 3.
Are recycled to the cytosol.
I'm sorry, Dr.
You see here another slide?
No, we're still on the immunofluorescence. Still on slide 3.
Oh, what is happening then? You see this, okay? And this one?
No.
No, your screen is not changing. Would you like me to share your slides?
Okay, you can do it.
I might be able to. Let me try.
And this one?
No.
No, your screen is not changing. Would you like me to share your slides? I'm sorry. Yes, that's not what I wanted to do. I might be able to. Sorry. That is not good. This one. There we go. I'm sorry.
I don't know what is going wrong then.
Sorry. That is not good. Which one? This one fine with you?
Yes, yes. Okay, you didn't see this yet.
No, we did not.
The most important functions for the human pathology are the oxidation of fatty acid, the very long chain fatty acid, the synthesis of bile acids, and the oxidation of branch chain fatty acids like phytanic acid, and the synthesis of ether lipids. Next slide, please. The synthesis of bile acids and the oxidation of branch chain fatty acids like we will discuss the Zellweger spectrum disorders. These are the disorders with the peroxisome biogenesis defects. You have also the group of the single enzyme defect, but we will not discuss in this presentation. Next slide. And these, can you do the next slide, Elise?
Yeah, it's a little slow, sorry.
Okay. These disorders are caused by mutations in PEX genes, and the PEX genes are involved in making peroxisomes or help importing the proteins into the peroxisomes. You have two types of proteins with the peroxisomal targeting signal 1 and 2. For the Zellweger syndrome patients, you have the PTS1, and in the cytosol, this protein is attached to a receptor and transported in the cytosol to the peroxisome, to the membrane, and here it is docking into the matrix, and then the ligand is dissociated and is recycled in the cytosol. Next, please. the most important functions. So here you have the plasmalogens, what is not well synthesized. Then you have in the blood plasmalogen deficiency because of the fatty acid oxidation defect. You have increased amounts of very long chain fatty acids, bile acids intermediates, and pristenic in plasma, and a high phytanic acid because of the alpha oxidation defect, and the pipocolic acid can be increased, and also in the urine increased amount of oxalate and glycolate. Next, please. Classically, it was the Zellweger syndrome, first described in 1964 as a cerebro-hepatorenal syndrome with a typical facial dysmorphism, severe brain abnormalities, and severe liver dysfunction, and also renal cyst. And Goldfisher discovered in 1973 that it is related to abnormal peroxisome, and now it is named Zellweger syndrome. Next, please. The cerebral abnormalities are very severe in the severe type, and especially polymicrogyria, and also subcortical cyst, but also germinal-lytic cyst. Next, please. Those polymicrogyria you can see very easily on the MRI and on pathology, and it is especially near the adjoining the abnormal deep central sulcus. Next, please. And it is especially near the adjoining. Following the biochemical possibility to do the diagnosis of Zellweger syndrome, we have identified many other clinical severities. Also, those patients without a clear facial dysmorphism and having a more prolonged survival, sometimes even into adulthood. Next, please. Facial dysmorphism and having over time, all those old names in the past, we called them Zellweger syndrome, neonatal adrenoleukodystrophy, infantile Refsum disease. But now we call them as a group Zellweger spectrum disorders because they have the same biochemical abnormalities, but the clinical phenotypes are much wider than originally thought when the Zellweger syndrome was described. Next, please. And now we classified these disorders in three groups: the neonatal infantile onset, the childhood onset, and the adolescent adult onset. And in all the three phenotypes, you have an impaired sensory hearing deficit, ocular abnormalities, and also animal abnormalities. The neonatal infantile type that is the severe Zellweger syndrome with multi-organ failure and a severe neuronal migration defect. But the childhood onset has many overlapping symptoms as the neonatal infantile type, but much milder. And now we are aware of persons who are diagnosed at an adult age. And all these phenotypes, you can diagnose in blood the abnormal, many abnormal peroxisomal functions. Next, please. Phenotypes, you can diagnose in blood. The prognosis are depending on the severity of the clinical onset. patients with the classical Zellweger syndrome phenotype die. Most of them die with the first year of life. With the milder phenotypes can live into adulthood. And now most of our patients are even adults, usually severely disabled. There are rare patients who are completely, who present a completely normal intellect. But it is still a progressive disease. Next, please. The diagnosis can be easily be confirmed by metabolic screening. There are many possibilities in urine, in blood, and also, of course, the mutation analyzes the PEX genes. More and more, they are diagnosed by whole exome sequencing for developmental delay, and as an accidental finding in newborn screening for X-linked adrenoleukodystrophy, that when they have an increased very long chain fatty acids, especially when it's not clear what type of Zellweger spectrum it is, then it is important to do still functional testing in human skin fibroblasts and for trying to give a genetic diagnosis. Next, please. Follow up in our clinic. We do a multidisciplinary clinic for monitoring for complication and also, of course, supportive care and transition to adult clinics. We have at the adult outpatient clinic many patients now with the mildest part of the spectrum. We advise them to visit 2 times a year for children on the under 12 and after yearly. Next, please. They present low-fat soluble vitamins and what can be easily supplemented. And bleeding can be caused by low vitamin K levels, but also when they have a severe phenotype with severe hepatic function defects. So we see them, we do a laboratory checkup once a year. Next, please. DHA supplementation, docosahexaenoic acid supplementation is no longer advised because it doesn't do anything functionally. And the phytanic acid restriction diet is usually not necessary in the milder patients. For more severely affected patients, gastrostomy is usually needed for feeding. Next, please. Important is to diagnose adrenal insufficiency because you can treat that also. And we saw about 30% of the patients develop adrenal insufficiency. And adrenal glands, they produce stress hormones, as you know, and some patients are asymptomatic, but they get sick when they have fever or in a stressful situation. And you can treat them easily with hydrocortisone. We advise to screen the patients for insufficiency once a year. Next, please. They also can also present high oxalate excretion in urine, what can cause kidney stones, and usually in young children the risk is higher, and but when they are getting older, there are less severe excretion of oxalate, and treatment is easy with potassium citrate in case of high oxalate excretion, and they can prevent formation of kidney stones. So we advise in these individuals a screening for kidney stones by ultrasound once a year and measure in urine oxalate excretion once a year. Next, please. Long-term effect of liver cirrhosis include development of liver cancer. Only few patients have shown this problem, but it is a real problem, the cirrhosis in the liver. And especially adult patients, they suddenly can be very sick because of the liver cancer. So we are screening the patients with ultrasound every 12 months in case of liver cirrhosis. Next, please. But also when you see the milder cases, then you are aware that there is also the possibility of progressive leukodystrophy. What you can easily see on the MRI, especially the central white matter is abnormal, and also the cerebellar hemisphere can be involved. Next, please. Supplementation of the primary bile acid, cholic acid, is supposed to suppress bile acid synthesis and then decrease the accumulation of toxic bile acid intermediates in blood and organs. And it is also known to stimulate bile flow, what increase the amount of intraluminal bile acids in the intestine, and what promote the micellar stabilization. But although biochemical effect seems to be sustained, no really clinical benefits after 21 months of cholic acid therapy. Caution is especially needed in patients with advanced liver disease and cholestasis due to hepatotoxic effects. We know that in the United States they still are giving cholic acid, but we advise to be cautious to do that. Next, please. We know that in the United States. So what are we doing? Because we don't have a real therapy in these disorders. We see them next, please. Each year. There is in a multidisciplinary session with neurologists or metabolic specialists, gastroenterologists, ophthalmologists, audiologists, and a specialized dentist, because they have also problems with the teeth. When they are very young, we see them twice a year, and in the old ones once a year, and sometimes once in 2 years. Next, please. So, in conclusion, although treatment is currently only symptomatic, it is important to initiate proper supportive care and therapy to improve the quality of life. There are many strategies to identify potential treatments, but we are aware that for the interpretation of future therapeutic trials, it is a fact that some patients with prolonged survival present an insidiously progressive disease course despite normalization of biomarkers for paroxysmal disease. So when you think it is getting better, functionally, they are not getting better, but they are insidiously worsening. Next, please. That's what Mark told me to present with and discuss with you. Thank you. I'm sorry that I couldn't do the full screen. I don't know why. Okay.
No matter. Thank you very much. Great. That's super. Okay, so I think we'll move straight on then. So the next speaker is Maria Escola from Pittsburgh, I think, and she's going to be talking to us about approaches to the treatment of Krabbe disease. Thank you. So Maria, are you there?
Yes, thank you. Thank you for having me.
Thank you.
Let me share my screen.
Talking to us about
approaches
to the treatment of Krabbe disease. Thank you. So Maria, are you there?
Yes, thank you. Thank you
Super,
for
thank
having
you.
me.
Thank
Let
you.
me share my screen. Are you able to see my screen?
Yeah, that's fantastic. Thank you.
Okay. Just put it on this PowerPoint mode.
Yeah.
Okay, well, thank you very much for having me. I am currently Chief Medical Officer of Forge Biologics, as well as Professor of Pediatrics at the University of Pittsburgh. And I will be talking to you about FBX 101, which is an intravenous AAV gene replacement therapy that augments the effects of hematopoietic stem cell transplantation that you may know as more as bone marrow transplantation or umbilical cord blood transplantation. I'll tell you a little bit about Krabbe disease, and I'm going to focus in the infantile form. So this is autosomal, we call it autosomal recessive disorder, meaning that you inherit from each parent. Each of us have two different genes. We inherit one from the mother and one from the dad. These babies inherit, unfortunately, a mutated gene from the dad and from the mom. So mom and dad have a healthy one, which is why they don't have disease, and babies then inherit the two mutated genes, and that's why they develop disease. And it is caused by the deficiency of a protein that we call galactosyl ceramidase enzyme. When you don't have this protein, this causes demyelination, which is we have cells that wrap our nerves, and these cells are the ones that make myelin. So when you don't have this enzyme, you accumulate a toxic that we call cytosine, and that toxic affects the cells that wrap the nerves. And what these cells do is they help the conduction be very quick. And so that when we move our arms or we look at things or we hear things, we can process information very quickly. When these cells die, then all these areas become affected. And while this disease can present almost at any time in your life, then 85 to 90% of the cases are between birth and 12 months of age. And when you have it at this age, because your brain is growing very fast and producing a lot of this myelin, these babies are the ones that have the most symptoms, and they get really affected and progress very quickly and die by 2 years of age in average. It is a very rare disease with only 1 in 100,000 babies being affected. The current, we call it standard of care because it's really the only treatment, is giving a transplant, a bone marrow transplant or an umbilical cord blood transplant or other form of transplantation of what we call hematopoietic cells, so cells that are derived from the bone marrow and that constitute the cells that circulate in our blood, so red cells, white cells, and platelets. So it is this treatment, unfortunately, while it improves a lot, the neurologic symptoms in the babies is not curative. And I'll tell you a little bit about why it's not curative later on in the talk. But telling you a little bit about the symptoms, this baby on the right side, you can see is arching his back. And this is one of the symptoms that we see. At the beginning, they just become really irritable. Then they have difficulty feeding, and they can aspirate the food and cause it goes into the lungs, so you can have a pneumonia. And then you can have progressive, we call it spasticity, which is tightness of your muscles. You see these babies' legs are kind of very tight and straight, and with it pointing the feet. and the hands are very tight also in the fists. They can have cognitive deterioration, they become blind and deaf, can develop seizures, can develop something we call dysautonomia, which is a lot of temperature instability and changes in heart rate and blood pressure. And then severe apneic episodes, which means they stop breathing for many seconds and eventually can't breathe again. And unfortunately, when they pass, usually it's because of very prolonged apneic, so where they stop breathing and then the heart has irregular beats and then they pass. So we conducted a natural history or natural progression just to understand what were the symptoms so that when we address the treatments, we could understand what is it that we're trying to stop. With these rare diseases, sometimes we have case reports or accumulation of several cases, but what we tried to do was prospectively understand what was happening to these children and how they were progressing. And over the years, I've been working with this disease now for more than 20 years. I saw 123 babies. One of the things we found out was that unfortunately the age of symptoms, which in the babies less than 6 months is about 4 months, and the age of diagnosis is quite separate, meaning there's a lot of time that passes between when the baby has symptoms and when the baby gets diagnosed, with a delay of about 3 months in average when we look at the entire population of the babies less than 6 months, while the more than 6 months, it was even more delayed because now the presentations is maybe not as severe, and where there is maybe delay of gross motor skills, some irritability, and eventually the family gets very concerned, and then they get the diagnosis. And in this case, the diagnosis was even further delayed to about 4.6 months. So we published this just to kind of have a reference of these are the babies that we treated what we call palliatively, meaning trying to decrease the symptoms and use medications to help them, but those kids unfortunately couldn't have a transplant because they were too sick. Okay, so one of the things we learned from actually checking their siblings when they were born and we diagnosed them at birth was that there were already apparent changes in the brain MRIs. And we could see that their nerves were conducting a little slower than normal. That's what the NCV stands for, nerve conduction velocities, as well as some other tests that we can do of hearing, where we can see that they are processing that very slowly too. And they were not yet symptomatic. The tightness in the muscles increases initially, but then as the peripheral nerves, which are the nerves that conduct impulses from the brain and spinal cord to the muscles, as they get affected, then the muscle tightness actually becomes very floppy. So their muscles become floppy after about 12 months. So they go from very tight to being extremely relaxed. They also experience these episodes where they stare at things when they breathe, and they don't have the apneas that I described before. Their breathing is very shallow. They have difficulty tracking with their eyes. They get very constipated, which means they cannot pass their stool very easily. They can have orthopedic complications, like, for example, subluxation of the hip, so the hip bone kind of comes out of the hip socket, or they have the temperature instability and heart rate issues that I explained before. So what is this umbilical cord blood transplantation or bone marrow transplant? So in these diseases that progress this quickly, we try to obtain the graft, so what we're going to give the baby very quickly. With bone marrow, unfortunately, it takes longer because you have to contact the donor, and then that person has to be available so that you can harvest or take out a sample of their bone marrow and then give it to the baby. This takes, in average in the US, about three months. So that's too long for these babies. So the advantage of having umbilical cord blood is that there are cord blood banks where there are many, many millions of cord blood units that are available, and you can find a match very quickly, and you can transplant these babies within 2 weeks. So that's why we use this source. And what this cord blood has, you see in the picture, there's a placenta that is kind of hanging, covered with that blue wrap. It's wrapped with a blue cover, and you can see the umbilical cord. And so what you do is you drain the blood from the placenta, you accumulate that in a bag, you take it to a lab, you process it, and then on the right side, that's kind of the final product where you see two little compartments, one that has about 30 milliliters of blood and the other one has 10 milliliters of blood. And so what you give is the one on the left, and the one on the right you save in case you need more cells or you need to look at something that was, let's say, unexpected. So you take this sample, the one on the right side, you can also use to test what their levels of enzyme of this protein that you're missing are, because we don't want to give a baby the disease, right? So we have to measure that. So for each baby, you find about 5 potential cord bloods, and so you can choose the one that looks the healthiest and has the highest enzyme, and then you can infuse this into the baby, and that's how you do the transplant. Now, for the transplant to be able to take, you have to give a little bit of chemotherapy. So when I started working on this, the chemotherapy that was given was very toxic to the brain, and that was not a good thing for these babies. So in Pittsburgh, we developed what we call a reduced toxicity regimen that was really designed for leukodystrophies, in which we try to reduce the toxicity as much as possible in the brain. And by doing that, we were risking not getting a good graft, but we thought, it's better that babies live than die from the treatment itself. And so fortunately, we found out that they didn't graft, the great majority of them, and the survival has been 100% now after 28 patients. So I'm just going to walk you through this quickly, but back in 2005, I published the outcomes of using this cord blood transplant with the more toxic chemotherapy, and we found out that if you had symptoms, it was going to be too late to really benefit from it. Then we followed this same cohort of patients for many years, and after an average of 15 years, we then published what we call the long-term outcomes. What you see on the right side, on the upper figure, is where we are comparing the developmental age against the chronologic age. So if you're a 2-year-old, you should be developmentally like a 2-year-old. So you should be in that gray shaded area, which is kind of the range of normal. Every line there is a patient with a different color, and every dot is a visit. So we looked at, in the upper figure is the cognitive. You can see that they were developing close to normal, although some were a little bit delayed, and that was mostly caused by their inability to move well their hands. In the motor, what we call gross motor, so big movements, so like learning how to sit, how to walk, how to run, we saw an initial improvement, and then at around a year of age, which is when you learn how to walk, we started seeing a plateauing, so not as much development, and we didn't understand why at the beginning, but by doing a lot of testing, we found out that the cord blood transplant, so the enzyme that we were giving, was able to fix the demyelination in the brain, so we didn't see any more progression of demyelination. However, the peripheral nerves seemed to initially improve, and then as time was going by, the disease progressed in the peripheral nerves, which make them very weak, and then they had, unfortunately, inability to walk. So of all this cohort of patients, there were about 18 patients. Only 3 of them were walking independently, while there were others that were walking with devices like walkers, and then some that were wheelchair bound. So that was not an ideal outcome. So then we started working on how can we improve this. So I had the opportunity to work with Dr. Jude Samolsky, who's a very famous gene therapist, and learn from him this way to treat with a vector. And this is like a virus, but you take out the part that causes disease. And you can actually use this. So in the figure, you can see this virus that looks like the coronavirus. And inside, there is is you are able to put the gene in the coding sequence. You can insert the gene that you want to replace. And this infects the cell, just like any virus would. And once it's inside the cell, the outside of it kind of breaks into little particles. And as you see on the right part of the figure, it injects that sequence, and then that is translated into the protein that it's missing. And the nice thing about this viral vector is that it doesn't integrate into your DNA, so it doesn't cause all the problems. Is quite safe because it just is produced without integrating into your DNA, and then you can secrete the protein in very high amounts. And this can be designed so it actually goes preferentially to the peripheral nervous system. So this type of approach is very useful in many diseases because you can design it to go to where you want it to go. And in this case, it provides a long-term correction. So once we found out that we could do this in collaboration with some doctors in Philadelphia, Dr. Wenger specifically, and Dr. Raffi, they looked at the mouse model of Krabbe. We are very lucky that we have a natural mouse model and a natural dog model of Krabbe disease that recapitulates very closely the human disease. So what you see on the left is we looked at the mouse, let's say natural mouse that is not treated. That's the one you see in the red. And what you can see the days in the bottom. So how many days they live. So you see that by 50 days they are dead, the ones that are not treated. Then in black, you can see what happens to the ones that get the bone marrow transplant. So they also die, but it takes a little longer. In the dotted line, you see the ones that get treated just with the gene therapy. So very similar effect than transplant. But when you combine the two therapies, you get the blue line. So you get this synergistic effect a lot better than any of those independently. And so that was very exciting to see that. And so then we try to understand, okay, how much of it do you need? What is the dose? So in the graph on the right side, you can see that we have different doses that are going higher and higher and higher. And you see the axis on the left where it says survival, age in days. So what this shows is that the higher the dose, the more they survive. But so we didn't know what's the right dose in humans, or when do we need to give the transplant in relation to the gene therapy. So we did other experiments showing that if you give the gene therapy like 1 day after transplant, you get a great effect. 5 days, also great. 10 days, very good. 20 started to go down. 30 was too late. So we kind of got a sense how much time we had to wait to be able to give the gene therapy. And then this is a very busy slide, but all I want you to focus is on the figure on the left side. You see the different tissues: brain, a part of the brain called the cerebellum, the spinal cord, and the sciatic nerve, which is one of the largest peripheral nerves we have. And then we look at the level of this protein, how much of it can we get by doing these treatments. So in orange, you see what a normal mouse that doesn't have Krabbe disease looks like. And the black bars are showing you what we thought was the right dose. And you can see that where it says sciatic nerve, the black is actually much higher than the normal. And then the other kind of blue with an orange line around, that's the very, very high doses. So we wanted to see what happens if we kept on increasing it, like 4 times more. And yes, we got more, but the truth is we didn't need more. So we decided to use what we call the target dose. So on the right side, these little squares here with some circles, those are actually peripheral nerves. You look at it in the microscope, and you just have to see that on the right upper quadrant, it's like very messy, very swollen, lots of nerves that don't look very normal. The normal ones are on the left side, left upper quadrant. And the lower ones are on the left lower quadrant is our target dose. Looks pretty similar to the normal. And the other one was 4 times more, which also looks normal. So we got comfortable with that dose. Then we went to the dogs and then did the same thing. We transplanted and also gave them gene therapy. And this is in collaboration with some doctors at the University of Pennsylvania that have the dog model. So the left one that I'm going to play, you can see this is a natural Krabbe disease in the dog. So the dogs, unfortunately, by 14 weeks, you have to sack them because obviously it's their humane endpoint. The next one that I'm going to play is the one that was treated just with the viral vector. So a lot better. However, you still see some weakness in the back legs. And then the last one is the combination therapy. And you can see that this dog is completely normal. This was sacked at 104 weeks because of the way the study was designed, not because there was any sickness. In fact, his neurologic exam was completely normal. And we found out that he had good levels of this protein in all the brain, peripheral nerves, and intended target tissues. Okay, so then from there, we decided to go to humans. And so as of today, we have treated one patient who did really well, and we are continuing now to recruit more patients. The way this trial has been designed is that we are going to treat 6 patients initially. The first 3 are going to have a very low dose, so lower than what we saw as a target. And the next 3 patients are going to have a higher dose, which is the one we think is the right target dose. But we have to do this because we have to make sure there's no toxicity in babies. So we have to start with lower. So these babies are going to be babies that are pre-symptomatic, that are eligible to get the umbilical cord blood transplant. And then while they're getting the transplant, approximately 3 weeks later, we're going to infuse them with the gene therapy, which is just an injection in the vein of this product. They have to be diagnosed with infantile Krabbe and be between birth to 12 months. And again, they have to be eligible for transplant. What we're going to look and see if there are any adverse events or what we call serious adverse events. So is there any toxicity? Is there anything that happened that we were not expecting, or things that we believe are caused by this gene therapy? And then we're going to see if it affects at all the engraftment of the transplant, meaning do they take the transplant? Then we're going to test and see whether their movement, gross motor skills are better, so better than those that you would get from transplant alone. And our hope is that we can achieve a functional age equivalent of 12 months, which is when you start walking, by about 2 years after treatment. So that will be the later we would like to see that, right? So hopefully we'll see the babies develop normally, but we don't know yet because we have only treated one patient. And we're going to explore some markers like measuring their nerve conduction, measuring how they process what they hear, looking at the MRI, looking at some biomarkers like cytosine, which is what they accumulate that I mentioned was very toxic. We're going to see how much their enzyme increases and then how they develop in general with cognition, language, their ability to move their fingers, and their ability to be independent. That I mentioned was very toxic. So in summary, umbilical cord blood transplant provides ongoing replacement of the deficient protein, improving the brain outcomes. However, the peripheral nerve disease is only temporarily improved. Gene therapy corrected both the brain and peripheral nerve disease in the animal models. And this new therapy that we call it BX101 has the potential to correct both the brain and peripheral nerve and also prevent the immune response against this gene therapy, since they have a new immune system that actually carries the protein. And this is given after cord blood transplantation. So we're very excited, but obviously it's too soon to know what the effects of this therapy is in kids. So Forge Biologics is going to be opening clinical trial sites in Europe to treat Krabbe patients. Currently, we are opening a site at the University of Michigan. It's going to be opening very soon. The UPMC activities are going to transfer now to this hospital. And we, as I said, we will be opening more sites in Europe. And we are also going to actually start another trial where we are going to expand the age criteria and where we would be able to treat patients that also have already received that transplant. The principal investigator for this site is going to be Dr. Mark van der Loop, and I just wanted to thank all the people that have. It's much more many people than in here, but these were the say closest advisors and collaborators at the University of Washington, Mayo Clinic, Cornell, University of Pennsylvania, and also at Jefferson's Medical College. Dr. Wenger was instrumental in this. All my fellow colleagues at the Program for Neurodevelopment in Rare Disorders, Dr. Sabolch, who did the reduced toxicity conditioning design, and Dr. Randy Windrich, who was the PI at UPMC and treated the first patient, as well as all the families that have come to our program, and all the foundations and organizations that are always helping and sponsoring our work.
Thank you, Maria.
Thank you very much.
Very kind and very exciting. I think we're running a little bit behind time now, so we'll just move on, if that's all right. But that's really exciting, and the videos are very, very compelling. So next we have Caroline Sevin from Kremlin-Bicêtre, and we have two talks actually, I think, on MLD. So Caroline, are you there?
Hello, yes, I am there.
Super. Hi. So next we have by the sea.
Oh, I cannot
wait. Stop share. Okay, I
have to stop. Maria, thank you.
Yes.
Okay. I will try
by the
to
sea.
share my screen. Oh, I cannot
wait. Stop share. Okay, I have to stop.
Maria, thank you.
Yes.
Strange because ça fait pas ça d'habitude.
I can see you by the sea.
Yes,
and,
but it doesn't work, I think.
I can't see any slides.
Okay, that's okay. No, it will be okay.
It works? Okay. Yeah, something's happening. Fantastic. Yes, absolutely super.
Je vais parler en français.
I'll speak French if that's okay, says Caroline. Good afternoon, everybody. Rather good evening. It's close to 6 p.m. I can see there are 60 people, 60 families logged in. Thank you so much for being here.
Bonjour à tous et à toutes.
As I was saying yesterday, I prefer to speak French, and my slides are in French, because usually we meet in person and we speak French during the meeting. But like I said yesterday, I hope that next year we can go back to our usual modus operandi and get together in person, which is much better to promote interaction. So I'll speak French, but I know we have very good interpreters. So the purpose of my talk, I'll try to keep it short. I understand we're slightly behind schedule, and also I know that there's going to be another talk on gene therapy, ex vivo gene therapy. Francesca Fumagalli will be presenting that. There's hope at the end of the tunnel when it comes to Krabbe's disease, and so she'll discuss treatments that have been approved for metachromatic leukodystrophy, early onset MLD. So I'm not saying I have all the answers. Let me tell you more about MLD. This is a disease that is one of the most widespread leukodystrophy. 1 out of 45 or 1 out of 60,000 people, depending on the country. So it is a recessive autosomal disease. It's basically a lysosomal storage disease that is caused by mutation in the ARSA gene, which produces the aryl sulfatase A enzyme, which is involved in the breaking down material that you found throughout the body, but mostly in the brain, in the cells that produce myelin. I'm talking about the oligodendrocytes. So these large lipids called sulfatides build up, and this causes demyelination in the brain, but also in the peripheral nerves, and this causes neuronal degeneration. And there are many other mechanisms that are involved that they don't know inside and out. So inflammation, oxidative stress, energy, metabolism. And it's important to say that because we know that once the symptoms here in this disease, there's no treatment that can stop the disease. And there are other avenues we could explore, gene therapy and other potential mechanisms that could be helpful in improving matters. So clinical forms of MLD, historically speaking, like other lysosomal storage diseases, the clinical form depends on the age of onset. The age at which symptoms appear, at least in France. Obviously, the ratios, the percentages vary from one country to another, but in France, the most frequent form is the most severe form, the infantile form that appears between 1 and 2.5 years. And then you have the early juvenile, the late juvenile, and the adult onset forms. And now we tend to use just two different groups. The early forms before age 4 and the late onset forms after age 4. So we decided to go with just two categories because in the early forms, whether late infantile or early juvenile progression is very quick. Once the symptoms have appeared, there is no treatment even to improve the disease, as we will say later. These patients are candidates for ex vivo gene therapy, in other words, homograft or self-graft. And then you have late onset forms of the disease after age 4, 5, 6. Actually, it's a mistake. It's not 4 years. It's supposed to be 6 years after age 6. Now, these diseases are much more variable, whether in terms of age of onset, severity, or rate of progression. So when you have a disease that appears after age 6, it progresses less quickly, and a bone marrow transplant, an allo transplant can help, and this is currently underway. I mean, the evaluation is currently underway. There are ex vivo gene therapy trials underway. So the diagnosis is mostly clinical in nature. I'll say a few words about that. And then you have the brain MRI we can use to diagnose the disease. It may look normal at the beginning of the disease, and very quickly abnormalities will show. Abnormalities affecting the myelin. See those highly diffuse bilateral symmetrical white spots on the MRI. If you look at the nerve conduction in the peripheral nerves, which are also affected, there is a slowdown in nerve conduction, and this shows neuropathy in the peripheral nerves. And then you have an association between the MRI and the clinical signs. So you measure the enzyme activity. You also measure the compound that builds up in the urine. And this is what we call sulfatidyluria. So then you combine the two exams to achieve a reliable diagnosis. And you confirm it with genetic diagnostic, and you look for mutations in the ARSA gene. It's important because, on the one hand, this means you can do genetic counseling and also prenatal diagnostic, because PND is possible for those diseases. So the ideal treatment, what does it look like? Let me say a few words about the treatment, bearing in mind that, once again, Francesca Fumagalli will talk about that in a minute. Now, the ideal treatment should be a drug that can either cross or avoid the BBB, the blood-brain barrier that protects the brain, but that also stops us from injecting the drug into the brain. So it's an obstacle. So the drug should diffuse sufficiently. It has to go to the right place at the right time, so get to the right cells. So it's a lot of boxes to tick. And also, it should lead to stable expression of the therapeutic compound over time, or you need to administer it again over and over again regularly. And there should be no toxicity. and also to avoid overexpression. And you need to administer it as early as possible. See the curve in this graph, and this is true for a lot of neurodegenerative diseases. Very often, there's an initial phase during which the child develops normally, and then things stagnate. So when the child develops normally, we call him pre-symptomatic, but when you see a stagnation in motor, in the learning of cognitive or motor skills, you call it the early form of the disease. The disease is incipient, and then there's a very rapid decline, rapid regression, both in terms of cognitive and motor skills, and most of the time it is then that the problem is diagnosed, assuming there's no family history of the disease. And then there's a new phase where things plateau, and this is the late stage of the disease where complications emerge, disability, becoming bedridden, etc. And when that happens, as you can well imagine, it's going to be more complicated to propose a treatment that can turn things around. So ideally, prevention is key, and it's probably the easiest way. And also stop, arrest, or attenuate the disease. That means the disease has already appeared. That's the big problem. And then repairing the problem, unfortunately, at this stage, that's still impossible. So, treatments available for evaluation. I'll say a few words about bone marrow transplant, stem cell transplant, umbilical blood transplant. I'll say a few words about ex vivo gene therapy, intrathecal enzyme therapy. And there are other combination treatments that are currently being evaluated, and when they become available, they can be administered. Again, these are combined treatments. The previous talk by Maria Escolar clearly showed that it is probable that once the child already has symptoms, or when you have very aggressive forms of the disease, such as early onset forms of the disease, one drug or one treatment is not enough. You probably need to combine several. So, treating the symptoms, most of the time, the patients that I see already have symptoms. The disease is already active, so they have symptoms and things are deteriorating. And at the moment, there is no treatment to stop those forms of the disease. I'd like to emphasize how important it is to treat the symptoms. We're not treating the disease. It doesn't stop. We're not able to stop it yet. But treating the symptoms means the child will be more comfortable. And when a child is more comfortable, your abilities, your capabilities are better and higher than when you're stiff or in pain. So it's important to treat the symptoms and to treat the symptoms as early as possible. So you need to anticipate. We know a little bit how the disease will progress, so don't wait before you administer the drug. Same thing, the wheelchair, the orthotics, everything. Just stay ahead of the curve. Treat as soon as you can so as to maximize the capabilities of the child. But for that, you need to fight the stiffness, fight the pain, etc. So I'm not going to spend too much time on this slide, but it's really an important message. You need to fight these symptoms. Promote motor skills through physical therapy. Psychomotor skills need to be improved. If you have problems swallowing, for example, that's something you can help by treating the symptoms. And also, we need to bring everybody together. Multiple disciplines need to work together. Nutritionists, orthopedics, and physical therapy, occupational therapy, psychomotor skills, neurologists, psychologists. Everybody needs to work hand in hand so as to improve the level of comfort and also the function level of those children. So, umbilical blood transplant or bone marrow transplant, whether the cells come from a related or unrelated donor, the goal is to modify the natural progression of late onset forms of MLD. But for that, you need to perform the transplant very early on, ideally before the clinical signs appear or at the very beginning of their emergence. And yet, with this transplant, there know parts of the disease that are impossible to prevent or stabilize, or that are difficult. For example, impairment of the cerebellum, of the basal ganglia, of the peripheral nerves, etc. And those problems are poorly corrected. Now, when it comes to early onset, when you perform the transplant, before the symptoms appear, you modify the progression of the disease. That's clear. You see things that are different. The disease expressed differently, but most of the time there are symptoms that appear, and it's a neurological disease that leads to significant, sometimes severe problems. Now, early symptomatic forms, that treatment is not, treatment then is not advised because it doesn't work, and the cost-benefit ratio, the risk-benefit ratio is not favorable. Now, this is work by a German team, and in juvenile forms of the disease, they compared children who received or did not receive a transplant. As you can see, in children who received a bone marrow transplant, you see motor skills are better preserved, cognitive skills as well. These are the two yellow curves on the right-hand side, and yet we still find there is a deterioration. So this study set a number of criteria for proper prognosis. In other words, these are factors that can tell you, yes, the transplant does have a beneficial effect, but you need to treat early, and you need to treat at a time when there are pretty much no motor skills. The GMFC score should be 0 or nil. Now, I'm talking about the gross motor function classification. The IQ should be higher than 85, so basically no cognitive impairment at all, and the symptoms should appear after age 4, and the demyelination score on the MRI should be relatively preserved. It shouldn't be too high. Another therapeutic approach is currently under evaluation for MLD, so intrathecal enzyme replacement therapy, ERT. There was an initial trial. Now the goal is to administer on a regular basis a recombinant enzyme via a small catheter that you can see on the right-hand side. There's a small chamber for injection purposes, so the chamber is inserted under the skin, and the product goes into the LCR. So, how to choose the optimal dose? There's currently a phase 2-3 trial that is currently underway. The enzyme is administered not every 2 weeks, but every week, and the dose is slightly higher. And the study will tell us whether or not this treatment can benefit children. Now, gene therapy, ex vivo gene therapy. Francesca will tell you more about it. This treatment, this medication, received a marketing authorization in December 2020 for pre-symptomatic, so late infantile or early juvenile forms of the disease, so at the very, very beginning of the disease. And in France, well, that's for Europe, but in France, since the end of 2021, it is possible to treat pre-symptomatic children only with the late infantile or early juvenile forms of the disease. And then there's a clinical trial for late infantile forms of the disease that's currently underway. So I'm sure you understand by now that the treatments that we propose must take place early and ideally before the symptoms appear. So, when there's no family history, unless you have a DPN, a prenatal diagnosis, or rather, how can you treat the children early enough? And when we see the children, when we meet with them, by definition, they're already symptomatic. So the idea is to look at symptoms, the very first symptoms of the disease that could help us diagnose the disease earlier. So I'm showing you this slide because there are results from a study performed by a German team In about 100, the interpreter got distracted. Please apologize. Please, my apologies. What do we see here? In the late infantile form, the initial symptoms of the disease is mostly motor symptoms. So it may not be completely true, but these are the symptoms that are expressed the most at that age. In the early juvenile forms, we see a little bit of both. You find both motor symptoms and cognitive symptoms, problems at school, learning problems, mental health problems, attention deficit problems, which can be signs that can help diagnose the disease. And when you move to the late onset diseases, the cognitive share of the early symptoms becomes higher. So at the end of the day, all children develop motor and cognitive symptoms. So what are we seeing? Together with Dr. Monsa, who's an intern in motor pediatrics, we tried to retrospectively look at a cohort of about 80 patients, and we looked at what the disease looks like when the first concerns emerge. So who is the doctor? How many patients consulted with that doctor, etc., etc. So I'm going to show you the early results because the study is already underway. We got all of the data here from the French database, but we haven't fully analyzed the data. So I hope that this will give us interesting information on who to target so we can train them on how to ensure an early diagnosis of MLD. So this is something that I can tell you more about next year when we have all of the data, but I really believe that this is going to be useful and interesting.
The breakdown in France, we have a majority of late infantile forms. It's not like that in other countries, like Germany, for instance. They have more juvenile and juvenile late forms. We have 80% of infantile late onset, and then early juvenile and late juvenile onset. We haven't looked at the adult onset form, and for the delayed juvenile, when you have 5 children, it's going to be very difficult to conduct an analysis with those few cases. We tried to look at their siblings, whether they had siblings. More than half had siblings, and when there were siblings, in our cohort, we were able to screen 30 children who were younger, 30 younger siblings, so boys or girls. And out of the 30, 24 were infantile onset forms, out of which 9 were screened at a pre-symptomatic stage. Among them, even before the gene therapy existed, they were able to receive an allogenic graft. Others, unfortunately, could not benefit from any kind of treatment. And finally, some were able to receive the gene therapy once it was developed. The very first symptoms that triggered concern in the parents. We've been trying to do this for several years in our reference clinic to understand the natural course of the disease since the beginning. What do we observe? We observe that, roughly speaking, and here we're going to focus more on the infantile onset forms because those are the ones that we more frequently find in our cohorts. And in those infantile late onset forms, we find the data that was published by the German team.
In the infantile onset, there are many motor disorders, balance issues, or delayed psychomotor development, or what parents refer to as delayed psychomotor development. There was stiffness as well. And once the parents start worrying, we're not in the regression phase. Only 16% of the parents say there is regression. So usually they start worrying before the child reaches the regression phase. And there are very few cognitive signs in the infantile onset forms, whereas in the early juvenile onset forms, there are cognitive symptoms, and in the late juvenile forms, there are many more cognitive symptoms. I am showing you here the pie chart, and in purple here we have strabism, because that is something often observed in 10 children in the infantile onset form. Recently, there was a paper according to which once the strabism is acute, it could be an early sign. It is not something that we have been looking into until now. And that's precisely why we do those studies, because we're looking for signs which maybe did not seem to be meaningful and seem to have now the capacity to help us diagnose and screen children earlier. We also try to understand who the families talk to. First of all, they talk to the pediatrician for the late infantile onset and early juvenile onset forms. They also talk to the psychiatrist for the late juvenile onset forms. And that's interesting, because until now we've been trying to disseminate information and increase awareness with the pediatricians, but they're not the only ones. There are other people involved here, psychiatrists, orthopedists, and so we have to really target all of these healthcare professionals to help them diagnose the disease. The figures here are very saddening, but unfortunately, in most cases, 2 healthcare professionals are seen before a diagnosis is made, which means that the diagnosis is delayed due to the fact that several healthcare professionals have been seen. I mean, there's time to wait between 2 appointments, etc. So that delays the diagnosis. In the infantile late onset forms, there seems to be a delayed diagnosis by approximately 1 year, and that's huge. That's way too long. And I had done the same study 10 years ago, and it hasn't changed really. The figures were the same 10 years ago. And we have to do something. There must be something we can do to improve and shorten the time before the very first concern from the parents and the diagnosis. Late infantile, 3 months, to early juvenile, 6 months. We can understand because the parents are not immediately in a position to talk to a doctor or a healthcare professional, but the time between the first appointment and the diagnosis is 10 months, and that is way too long. I know the disease is difficult to diagnose, but still, we could do better here. One slide to show you the percentage of children who acquire or did not acquire the milestones for motor development and language. In the late infantile forms, onset forms, all the children did acquire some functions at a fairly normal age until they could sit up without assistance. And then all of a sudden we see children, a cohort of children who do not acquire some functions, such as crawling on all fours, standing without assistance, and walking unassisted. And we diagnose children at the age of 32 months. So what happens between 18 and 32 months? We're back to square one. Those signs are not even very early signs, and we really need to target them to diagnose the disease earlier.
This is rough data. We have not yet analyzed it. I just wanted to give you food for thought. We're still looking at infantile delayed late onset forms, very small cohorts, very few cognitive symptoms. I mean, here we're looking at the evolution of the disease, the natural course of the disease, very few cognitive symptoms, convulsions or seizures in 30% of the cases, abnormal movements, visual impairment, and also motor disorders. Most children either suffer from a pyramidal syndrome or cerebellar syndrome, peripheral ataxia. I mean, they may start all together or one after the other, but all these signs are present. Pain is also an evocative sign of the disease described by 80% of the parents, but I guess it's even more than that in real life. Swallowing disorders that appear in the natural course of the disease. And I put this here because sleep alterations are independently from the pain is something important. Caroline, I'm really sorry, but we're running out of time. No, I'm done, I'm finishing. That was my last slide anyway. So improving the early diagnosis, well, we need to define what we mean by pre-symptomatic or early symptomatic form. That's very important to discriminate when we start looking at possible therapies. Until when? How late is the ex vivo gene therapy efficient? I insist on the family screening and neonatal screening, and screening the siblings, the younger siblings is important. We have validated scores, they're easy to use, and also a European database has started. It's currently being built. It's called the MLD initiative, and it was initiated by the Amsterdam team. Thank you very much for your attention.
Really comprehensive, but really important flavor for the disease. So thank you. Right, so we'll move on now to Francesca, I think, Fumagalli from the San Rafael, and she's also going to talk about MLD. So Francesca, are you there? Thank you.
Hi, would you hear me?
Yes, super. Thank you.
I share my screen.
Yeah.
Excusez-moi, c'est le technicien qui vous parle.
This is the technician speaking. We have a small technical problem.
Super. Thank you. Yeah.
Could you give us 2 minutes? We just have to do one operation so that interpreting is heard correctly, because we have a slight technical problem with interpreting. Thank you.
And we need to wait 2 or 3 minutes to resolve the problem. I don't know if it's something to do with the translation. Elise, do you know what's going on?
No, I'm not sure what's going on, but it's on the English channel, I think. They might have some difficulties hearing you in English.
Yes, the English channel is having a very poor connection, apparently. So we're just changing the soundboard on the English channel to make sure that it is audible for everyone. Sorry for that. It's only taking a minute.
No, that's absolutely fine. Thank you. Okay, if anyone wants to sing or tell jokes, then please go ahead. Otherwise, we'll just wait for
Fumagalli, by any chance, do you have a headset or anything that could help us have a better sound also on your side?
Unos auriculares para que...
Mrs. Fumagalli, by any chance, do you have a headset or anything that could help us have a better sound also on your side?
Unos auriculares para que...
C'est bon.
Est-ce que vous m'entendez? Normalement, on est bon. Vous...
Should be okay. You can start again.
C'est bon.
Interprétation, Jérémy, ça y est, c'est remis.
Donc ça se met à jour, c'est bon.
Merci beaucoup.
Well, the computer had to be reset.
Merci, Jérémy.
You hear me and see my screen, right?
Yeah. Yeah.
The audio is doing better now?
I think so. Yeah. They'll tell us if not. Yeah. Thank you.
Okay.
Please go ahead.
Thank you for the kind invitation. Thank you to Caroline to introduce my presentation. And thank you to all the parents attending because it's so late now. So thank you for being patient and waiting for the last presentation. I will update you about gene therapy for MLD and just give you an idea of next steps. Thank you for being patient and waiting for. I'll try. So I start from the end of our long run toward gene therapy. That is the approval that was reached in December 2020 for gene therapy. And as you know, gene therapy is now called LibMeldy. It has been approved by Europe, in Europe, for two categories of patients, so the late infantile and the early juvenile variant.
I'm sorry to interrupt again. This is the interpreters. Apparently, the Zoom interpretation is not working for the moment for an unknown reason. Sorry again. There's a glitch on Zoom. I guess the connections are getting a bit tired. Sorry for that. We're just re-establishing the line. Thank you. For an unknown reason. Sorry again. There's a glitch on Zoom. I guess the connections are getting a bit tired. Sorry for that. We're just re-establishing the line. Thank you. Can we try again? Maybe the interpreters can start translating again just to check if we can have the sound.
Translator can hear me, right?
Yes, we can hear you.
Okay, so I was saying that we are starting from the end. So the approval of gene therapy in Europe, that is now called, this is a standard treatment called LibMeldy, and it has been approved for these two indications, the late infantile variant and the early juvenile variant, so the early onset variant of MLD. And in particular, who can be treated with this drug? The late infantile and the early juvenile children before symptom onset and the early juvenile children in the early phase of the disease before entering the rapid phase of progression, like Caroline was showing you in her presentation. And currently we are almost ready to treat the patients in 5 qualified centers. Why we reached this indication? I will try to show you the results of our clinical trial and what is going on. So just to explain to new person at this meeting what is gene therapy. Gene therapy is based on stem cells and in particular hematopoietic stem cells. Stem cells are the mother cells that give rise to the production of cells of our bodies, and hematopoietic stem cells are the mother cells of the blood. From hematopoietic stem cells that lives in the bone marrow, all the cells of our blood are produced every day, and from hematopoietic stem cell we can produce white blood cells, red blood cells, platelets along all our life. They can reproduce themselves, they can produce all type of blood cells, and they can travel throughout the body, throughout the arteries, and reach all the organs of our body and even the brain. So gene therapy exploits this function of hematopoietic stem cells to deliver the lacking substance, that is erythropoiesis A, around the body. What we do in practice? We collect the hematopoietic stem cells of the child. So we are speaking about an autologous transplant. We select the stem cells from the blood, and in vitro, in a lab that is now the company, we transfer to the hematopoietic stem cells the lacking gene through a vector, like a shuttle that enter in the stem cells and introduce in the DNA of the child a new copy of the gene. Then these corrected cells can be reinfused in the child but before infusing the cell, we have to prepare the child through a chemotherapy to receive these new cells and make space to the new cells. How we can know gene therapy is working? We will go through this question in my presentation. Is gene therapy safe? Did the gene-corrected cells engraft? Where are enzyme level restored? And could we prevent disease progression? All this information are presented in a paper that has been published recently by our group and describe the outcomes of 29 patients enrolled in clinical trial at our center in the last 12 years. More than 29 patients have been treated. As of today, we have treated more than 40 patients, but here we presented the data on the first 29 patients that reached a longer follow-up. They are 16 late infantile, 13 early juvenile, and we compare the results with 31 patients that in the past were followed at our center and couldn't be treated because already symptomatic. Is ARSA-cell gene therapy safe? We can say yes. ARSA-cell Solid-MELD was generally well tolerated. There weren't serious adverse events related to treatment, and there was no damage in the stem cells associated with the treatment up to now. Unfortunately, 3 patients died during the clinical trials. 2 were 2 early juvenile patients treated in a symptomatic phase that unfortunately progressed very fast and died due to disease progression. 1 died due to another event that was not judged related to gene therapy. There were another event related to treatment, was not a serious, not severe event, was the production of antibodies against erythropoiesis A enzyme. In all the cases, the patients who developed these antibodies then cleared the antibodies, so at the follow-up, the antibodies was no more present, and any side effect related to the production of these antibodies. Gene-corrected cells engraft. In these 2 graphs, you can see that the percentage of corrected cells in the bone marrow remains stable over time up to the latest available follow-up, both in the late infantile and early juvenile patients. Some of the patients have very high percentage, so up to 80 to 90% of cells in the bone marrow are corrected. Some other patients have slightly lower levels, but always stable over time. And on the graph on the left, you see that the gene-corrected cells increased over time in the first 3 to 6 months after treatment and then remain stable over time. This results in high level of enzyme. If we look to the enzyme activity in the peripheral blood, we see that our patients reach a very high level of enzyme, even above normal range. Normal range are represented by the gray area. And on the right graph, you can see that ARS activity is high, reach normal level also in the cerebrospinal fluid, that is the liquid that is around the brain, and we can collect through a lumbar puncture. So over time, our patient maintain good level of enzyme also in the cerebrospinal fluid. So the enzyme is produced in the brain. In terms of motor function, we compared the motor function of our patient with the unfortunate children that couldn't be treated. And you see, I'll try to explain the graph. You see that the motor function of the treated patients are really higher compared to the motor function of the untreated patients. In green, the late infantile patient, 2 years and 3 years after treatment. Their motor function are really high. It means that they are able to walk, while at the same age, around 3 to 4 years old, unfortunately, as you may know, late infantile untreated children are completely bedridden, are not able to move completely. This difference is also observed in the early juvenile group. In the early juvenile group, you know, we have treated both pre-symptomatic and early symptomatic patients. And you see that the motor function of treated patients remain quite stable, while the untreated patients progress and show a decline of their motor function over time. If we look to the severe disability, so the bedridden status, the capability of the patient to sit without support, you see that the patient in dark green, so the late infantile treated before symptom onset, never reached the severe disability, except in one case, that is a patient that was treated too late. In the early juvenile group, along the follow-up, we see that some patients unfortunately reach a severe disability, but a group of them maintain good motor capability, doesn't reach the severe disability up to the latest follow-up. In terms of cognitive ability, this graph is similar to what Dr. Escolar showed you. So the gray area is the normal cognitive development. So our patients in dark green and dark blue remain in the gray area, so shows a normal cognitive development over time, while the untreated subject have very, very compromised cognitive status. And this is what happened in reality. So thanks to gene therapy, we have patients going to school, a child that dreams to become a doctor, patients that are still alive and doing well at 11 years of age, while usually a child suffering from late infantile MLD is bedridden by the age of 3 to 4 years old. This is a child recently treated. This is a French child, you may know, can ride a horse while at the same age where a sibling was bedridden. So as you see, we could treat patients coming from many countries in the world, and we hope to treat many other patients with the commercial drug product. So we have said that gene therapy is safe, the corrected cells engraft continue to remain stable over time. ARSA activity is restored both in the blood and in the brain, and we could prevent disease progression, particularly in the patient treated really in advance to disease onset. What are the next steps? We are going to treat patients in other center in future. In particular, Caroline Seven was saying that patient could be treated in France. One patient has already been treated. Another center will be in Germany, another one in Netherlands and in UK. And other activities are ongoing in US. Another center will be in Germany. The long term of treated patient will continue over time, in particular not only for the patients enrolled in the clinical trial, but also for the patient that will be treated with the commercial product. We will have to continue to follow them and collect data on these patients, both regarding their disease status and the side effect of chemotherapy and gene therapy. So we will continue to follow them in our different treating centers to demonstrate long-term efficacy and safety of gene therapy. Another future perspective is the clinical trial ongoing on the late juvenile variant. In fact, the Libmeldi is approved for early onset variant, but we have to demonstrate that gene therapy is working and is safe also for the late onset variant. In particular, we are recruiting children with an onset between 7 years old and 16 years old in a new trial ongoing. Also in this trial, we have to enroll pre-symptomatic patients, so the younger brother of affected sibling, or early symptomatic patients before the children enter in the rapid phase of progression, because in the rapid phase of progression, it is too late to offer gene therapy. But the most important next step is to develop the newborn screening and to anticipate the diagnosis, as Caroline was saying. So we have to find the right way to perform the newborn screening, and some pilot studies are ongoing. And we have to demonstrate that newborn screening is able to detect children with MLD at birth. Some studies are ongoing in US and Germany, but other studies are under development in Italy, in France, and in other countries in Europe. And the other way we can have to anticipate the diagnosis is to detect as soon as possible symptomatic children, as Caroline was saying, and to anticipate the diagnosis in the siblings, the younger siblings. We have to speed up the diagnosis, not to lose time between the diagnosis of an older sibling and the diagnosis of a younger sibling, because a younger pre-symptomatic sibling can have access to beneficial treatment. So I thank you for the attention, and I thank you all the team working with us. Just to say that MLD children need a multidisciplinary teams made of neurologists, pediatricians, transplantologists, physiotherapy, psychologists. So we need a team that supports our great children.
Francesca, thank you very much. So that's another set of exciting data with gene therapy, which seems to be really delivering now after quite a long period of time. So that's really wonderful. Thank you. So Elise, I'm not sure how this bit of the session works. Could you give me?
Yes, absolutely. So we can invite the families that wishes now to raise their virtual hand if they wish to ask a question, and we will give them the microphone. So at the bottom of the screen, the people can raise their virtual hand if they wish so. So I will have the first person open the microphone. You have to open your microphone at the bottom. the people can raise
Yes,
their
hello. I don't know if it's me you were singing off.
Yes,
Yeah.
have the
Okay.
first
Thank you.
question.
Thank you very much. Thank you for this presentation and for the meeting. I have some questions for Yannick Cro. Thanks again for the presentation. Even if that's probably the fifth or sixth times I've got it, I do learn and understand something new each time. So thank you for that. I understand that JAK inhibitors' promise is not as good as expected, especially that the impact on brain is not sufficient. If I'm right in the interpretation, and at the same time, you seem pretty confident in finding a proper solution and soon. So I was wondering if you can explain us more about that confident intuition of yours that you have. I have a second question which is linked, and is that because listening to your peers' testimonies, we should consider more cell transplant, even for kiddos, meaning yet born infant? And my last question is there something that we families can do to help or foster that research dynamic? Even for kiddos.
Okay, thank you. So hi there.
And my last question
so I
is there
think
something that we families can
one
do
wants
to
to remain
help or foster
optimistic.
that
I think
research
what I'm optimistic about is that there will be other types of anti-interferon therapy becoming available. That is absolutely clear. There will be other drugs that will become available, and that people will wish, or companies will wish to trial in patients. So I think there is room for optimism in that regard. In particular, then that's in the direction relating to what might be termed anti-interferon therapy. So I am optimistic. I mean, there are certainly some diseases, and maybe at least one of them that we've heard about today, where there's not so much happening in terms of therapy. But I think that in the context of Aicardi-Goutieres syndrome, in relation to anti-interferon therapies, there will be other drugs to trial. Now, in relation to regarding your other questions, then I think what we've also heard from Carolina and Francesca is the importance of early diagnosis. And I think let's just say, for example, that JAK inhibitors are, they work absolutely brilliantly if you catch the disease early enough. I'm not saying they do, but there's one of two reasons why maybe they don't work. Well, one of three reasons why JAK inhibitors might not work perfectly. One is that they're not addressing the right basis of the disease, or not addressing all of the underlying problem. The second is that you're not getting enough into the brain, and the third issue is that by the time you start treatment, there's too much damage that's already been done, and that's a common theme. I think you've heard you might have heard talks about MLD, and the issue there is to try and make the diagnosis as early as possible. And so those problems will remain, and one can't tell how the new drugs will act. But even if they address completely the underlying basis of the disorder, we will still be faced with the issue of getting enough into the brain, and also the stage at which you start treatment. And you'll know that for a lot of the children with Aicardi-Goutieres syndrome, it takes a while to make the diagnosis. So I think that will be a problem. And then just because I don't want to I want to give other people a chance to ask questions also. But yes, I think one should, of course, consider other approaches. And for a long time, gene therapy has kind of promised, but has been problematic. And I think we're seeing real breakthroughs now in people's understanding of gene therapy and using the strategies that we've heard about today. And I'm not aware of anyone chasing that kind of approach in Aicardi-Goutieres syndrome. It wouldn't be surprising if somebody was, and maybe they should. And I would say, yes, they should. It's not me. It's not my world. I can't do that. But, I think that it would be great if some people were starting to think about that kind of approach. What can families do? Well, I think that the work that ELA does is magnificent. I think families supporting the work that ELA does and other researchers as they become interested in acardicutia syndrome. So those are a few answers. Yeah, thank you.
Thank you very much.
Thank you. So we also had a question early on today, Yannick, about asking if a graft was a possibility for acardicutia syndrome.
Well, I wouldn't say it's not a possibility, but I'd also say I've never heard. Some of the other Caroline may have an opinion here, but I'm not aware of anyone who's ever been undergone bone marrow transplant for acardicutia syndrome. I know that in relation to a related disease, another interferon-related disorder called SAVI, which isn't the same as AGS, but there is some overlap. I know of one case that was treated with a bone marrow transplant, and there was a good response in certain respects, which isn't the same as AGS, but is. I think, simply put, with these kinds of approaches, gene therapy, bone marrow transplant, you don't know what's going to happen until you try, and it's very difficult. But one of the issues about which cells are you trying to correct? If the disease is about blood cells that go into the brain, then that's one thing. If it's not about blood cells at all, then that's a completely different ballgame. So, yeah, I don't know if anyone else wants to say anything to that possibility. I don't know if anyone in San Rafael is doing AGS, for example. Francesca, have you thought about this? So, yeah, I don't know if anyone else wants to say anything to that possibility.
Okay.
I don't know if anyone in San Rafael is.
Then we'll switch. We have a question also for Caroline Sevin. There is a person that would like to know what is preventing newborn screening for MLD in France, like it is done for drépanocytose.
Oui, bonjour à la personne.
Hello to the person asking this question. I know who you are. In theory, in absolute terms, there's nothing standing in the way of that. Because there is a rationale now. There's a treatment that is available that makes it possible to stop the disease, and it's one of the criteria, right? There's an early stage treatment that's available that can stop the disease. Now, this is a rare disease, but it's not that rare at the end of the day. And so, in this configuration, neonatal screening should be a possibility. And this is true for other metabolic diseases in France as well. I think that in France we may be a little late in terms of the disease that we run through NBS. It's not true in other countries. Now, in terms of MLD and adrenoleukodystrophy, ALD, because the situation could be the same, there are lots of initiatives underway to try and provide NBS. And as far as MLD is concerned, there's a pilot study that's about to start. So we're not there yet. And it's not going to happen anytime soon. But I think we will get there eventually. But France is very much behind the other countries, and there are so many diseases to screen for. And I'm hoping that people will start thinking differently, because there's no reason France should do less NBS than other countries. Now, in any case, we need to discuss the reason why, the reasons behind it.
From a Spanish person asking, where can we have information about the pilot studies for newborn screening of MLD? There is another question in relation from a Spanish person asking, where can we have
I don't have the answer to that question. I think this is done on a country-by-country basis. So, if you're a Spanish family, maybe talk to your reference center in Spain to find out whether there's a study on the way, because an NBS study does not involve families. So they look at all of the babies in a particular region, for example, or in a specific area of a country. So during the usual NBS, for sickle cell anemia, for example, and other diseases, they can add MLD to the screening or other lysosomal storage diseases, etc. So this is done on a country-by-country basis. So look it up, see what pilot studies are being done in your country. But I think this is happening independently from families and physicians. It involves all of the babies in a particular region, in a particular area of the country. It's meant for babies, all babies born in the maternity ward. I hope that answers your question. I really hope so.
A couple of questions that were asked in written.
Yes.
Addressed to you. Maybe you can answer them.
Yeah, so the first question is,
Dr. Escolar, there is a couple
I'm the mother of a child who died at 9 months old. It seems particularly hard for the severe end of the spectrum as we don't have time to do anything for our children.
Answer them.
Unfortunately, because of the way the brain develops in the first year of life, it's so incredibly rapid that every day and every week makes a difference. And the only way to really to treat is really to prevent this from happening. In the US, there are 10 states now doing newborn screening, and we're able to detect them on time. I know it's hard for those who are already symptomatic because in the US, really there's not much that can be offered. There is another Quebec trial by a company called Passage Bio, and they will be treating symptomatic patients in their first part of the trial, just testing safety. They have to be less than 9 months of age. There is another Quebec trial by a company called Passage Bio, but it is very hard. And I think there is still a lot that can be done to improve their quality of life. They have to be less than to make sure that they're not suffering or that they're not in the hospital frequently. But I would focus on this area right now for those who have symptoms, because unfortunately, as I was saying before, time is of the essence, because once the tissue is damaged, even with the perfect therapy, even having protein going to the brain, unfortunately, you cannot repair what was already damaged, because now the problem is different. Because once the cells have died, and so it's not just the enzyme or protein deficiency. So I would just push for newborn screening for future babies, so this doesn't happen. The problem is different, is that the cells have died, and so it's not just the enzyme or protein deficiency.
There's also a question.
So I would just
maybe
push for
Caroline,
newborn screening
someone
for
is asking,
future babies.
does really the enzymatic replacement therapy works in MLD?
So does enzyme replacement work?
There's also a question for MLD. Yes, enzyme replacement therapy. Does the therapy works? Replacement therapy works in MLD?
Je réponds en français parce que je crois que je peux pas répondre. So does enzyme replacement work?
I'll speak French. Right?
For MLD, yes, enzyme replacement therapy. Okay. Does the therapy works?
Je réponds en français.
Well, that's the question that is being addressed by the trial that is currently underway. The first study, as I said before, is a phase 1/2 trial. And the goal of this trial was to check that the treatment is safe, that there are no severe adverse events or side effects. And also, the goal is to choose the optimal dose. The study is still underway. Unfortunately, it no longer enrolls patients. All of the children have already been included in cohorts. And so the endpoints are based on relative preservation of motor functions. So in Paris, we have enrolled a number of children. I can't give you the results because the study is still underway, so I'm not allowed. But by and large, I think that this treatment does have an impact. It does something, but it's not enough. As such, as administered today, the treatment is not enough to prevent the motor symptoms. that are deteriorating so quickly at the time of diagnosis, between diagnosis and initiation of the treatment. So the treatment is supposed to act very quickly, contrary to a transplant. So whether transplant alone or transplant plus gene therapy, one of the reasons why that doesn't work when the children already have symptoms, it's just, there are other reasons, but one of those reasons is that it takes a long time for the donor cells or the corrected cells to return to the brain so they can do their work. It takes 6 to 9 months, sometimes 12 months. It's shorter with gene therapy. Francesca can confirm that. Sometimes only 3 to 6 months, but for an allo transplant, between 9 and 12 months. So enzyme therapy acts quickly, yes, but it replaces the enzyme. Probably a transplant or ex vivo gene therapy will both replace the enzyme and may have other effects. That is, replace the immune cells, the macrophages in the brain that probably have a role to play, that don't operate very well, and replace them with healthy brain or corrected brain macrophages. So the answer regarding enzyme therapy, just to wrap up, I don't think it'll happen until next year because the trial is still underway and the last children have already been enrolled and recruited very recently, actually.
Another question from Daniel for the MLD in general. He's asking what is the genotype-phenotype correlation? Just, I'm guessing an explanation of what is that. What does that mean? Another question genotype-phenotype correlation in MLD. MLD in general, he's asking what is the genotype-phenotype correlation?
Of course, we can say that there is a genotype-phenotype correlation. That means that when you identify the genotypes, so the specific defect in the gene that the child has, you can say if this is very severe or a milder genotype. But there are many defects in the gene that the child has. Defect in the same gene, the ARSA gene. Some of them are very common, and we know them very well, and we know exactly there are many if they are severe defect or not, and we can predict the disease course, the disease severity. So we can define since the date of birth, for example, if the child will develop a very severe form, her disease variant, but in some cases, because the defect is very rare or is very mild, we cannot really know if the child will develop and exactly when he will develop symptoms. So in general, yes, there is a genotype-phenotype correlation, but in some cases not so easy to predict the disease course. If the child will develop and exactly when he will develop symptoms. So in general, yes, there is a genotype-phenotype correlation, but in some cases not so easy to predict the disease course.
So maybe we could conclude.
Can I say a quick word? Can I please answer? I can see there's a question
and we are
from a family that I know as well.
So maybe we could conclude.
How soon will we know whether the treatment for Graves' disease will also work for MLD? That's an important question. I may not answer it specifically, but generally speaking, I'd like to remind you that, of course, in those leukodystrophies, when you make scientific progress in one area, it's often helpful in other areas. It helps you develop similar approaches to treat other diseases. And maybe Francesca can tell us more about that. On ex vivo gene therapy for Krabbe disease? Has it begun? Yes or no? I don't know whether Angela is still here.
Thérapie génique ex vivo dans la maladie de Krabbe, en tout cas, ce qui avait été commencé ou non? Parce que je pense que la question portait.
But I think the question has to do with the combination of gene therapy and transplant. But ex vivo gene therapy is a good example. So transplant plus IV gene therapy. IV meaning intravenous. I talked with Maria Escolar and David Wenger quite a bit. At the end of the day, if you have an approach that works against Krabbe disease, it could actually be beneficial in terms of treating MLD, but things are still underway. Things are still in the preclinical stage. Now, talking about patients who are already symptomatic, the transplant must be done early on. You can't do a transplant in an infantile form of MLD. It's very risky when the child already has symptoms. There's a high risk of complications following the transplant. So, Professor Escolar's protocol looks at children who received a transplant at the pre-symptomatic stage of the disease. So that's the quote-unquote conventional treatment, the standard of care. And to that you add gene therapy. Maria, if I'm saying the wrong thing, if I'm wrong, do correct me. But when it comes to symptomatic children with MLD, yes, of course, IV or intravenous gene therapy is a possibility, bearing in mind that, as we said before, it is difficult to go back and turn things around, but this is a treatment that is fast-acting, so that could prove an interesting avenue. So when you combine transplant plus intravenous gene therapy, first you need to perform the transplant, and doing a transplant in a child that already has symptoms is a huge risk. At least in our experience, and Maria can tell you more about that, and then maybe Angela. So Maria first, and then Angela.
Thanks, Caroline. That is a very good point in terms of treatments for these two diseases. I think they should be tried just because they're so similar, and the way they progress is also so similar. Caroline, you're right about the risk of transplant in terms of when the patient is already symptomatic. For these two diseases, the reduced toxicity regimen that we're using has allowed us to treat some minimally symptomatic patients successfully. Right about the risk of but once they have more, when the patient is already symptomatic, abnormal signs and symptoms, and there's much more demyelination, it is too dangerous because they can die from the transplant, and obviously that's not what you want to do. So there is a fine line, but I do believe that either the approach that it is too dangerous that was explained with the lentivirus, or the approach that is a combination of so there is a fine line, but I do believe that are approaches that could be used for both. Either the approach that was explained with the lentivirus, or the approach that is a combination of transplant.
Yes, in principle, yes.
Are approaches that could be used for both diseases.
Approach lentiviral vector-mediated, hematopoietic stem cell gene therapy, but this relies on the possibility to overexpress the enzyme in hematopoietic stem cells. So this is possible for MLD. So for our approach, it's very nicely overexpressed in gene therapy, but this relies so you really provide an advantage over the physiological, over the conventional hematopoietic stem cell transplant. So far, the results that we have for the Krabbe really tells us that it is very difficult to reach this overexpression, enzymatic overexpression so far of GAL-C, the hematopoietic stem and progenitor cells. So this is something that is very difficult. It's an issue for hematopoietic stem cell gene therapy, because if you only have, I don't know, 2, 3, 4 the normal levels of enzymatic activity in your donor cells, this is something that it's not straightforward. For advantage as compared to the hematopoietic conventional hematopoietic stem cell transplant. So it is true that the clinical progression may be similar, but from the biochemical point of view, the enzymes are different. So since I'm not a physician, so I look from the basic, let's say, science. It is true that the clinical progression may be similar, but from the biochemical point of view, the enzymes are different.
tools
So since
to
I'm not a physician,
overexpress
so I look
GAL-C
from
as compared to
the basic, let's say, science point of view.
you can overexpress 100 times. There is a difference in the possibility 50 times, 100 times, while galactocerebrosidase to overexpress GAL-C as compared to possibly enough. So we are working in order to try to push this overexpression in the donor cells, or the other way could be to increase, to optimize, to maximize, we are working in order to try to push this overexpression in the recipient cells. So either way, or the other way, GAL-C, so for Krabbe disease, the situation is different than we see for MLD or for MPS1, for example. That this is another very nice example in which you can really overexpress the GAL-C. So for Krabbe disease, the situation is have a very remarkable result for MLD or for MPS1, for example. So there are very nice examples in which you can really overexpress the enzyme in hematopoietic cells, and then you do have a very remarkable.
And this is why maybe the combined therapies in some diseases, have a stronger rationale than in other diseases. So,
so it's really nice to have indication.
And this is why maybe the combined therapies in some diseases have a stronger rationale than in other diseases. So,
okay.
So it's really nice to have indication of efficacy of combined.
Elisa?
Yes.
Other questions?
Alors, il n'y a plus de main levée.
Nobody else has raised their hand.
Elisa?
We have received questions in writing, and of those questions I have not received an answer, will be addressed afterwards. After we hang up, you will get your answer in writing. I'm sorry, we are slightly behind schedule, but I would like to thank everybody for taking part in this meeting.
On Sunday, I know the family very much appreciate the time and effort you're giving them. So thank you also, Yannick, for leading the second half of the afternoon. On Sunday. I know the family very much appreciate the time and effort.
Thank you for family. Bye-bye.
Bye-bye. Have a nice rest of the day. Bye. Thank you also, Yannick, for leading the second half of the afternoon.
Thank you, Elise. Thank you, everybody. Take care.
Thank you, everybody, and thank you for family. Bye-bye.
Bye-bye. Have a nice rest of the day. Bye. Thank you.
Bye.